Hello, sir. Good morning.
Good morning, sir. Good morning.
Sir, বিপ্লব স্যার কোথায়?
5 মিনিট আগে কথা হয়েছে, আসছেন।
আচ্ছা, ঠিক আছে।
গুড মর্নিং স্যার।
স্যার, স্যার তো শার্ট পরেন, ড্রেস পরেন। আবার নতুন স্টাইল, শাম্পু পান্ডা স্যার।
Good morning, madam.
বিপ্লব শুনতে পাচ্ছ?
হ্যাঁ শুনতে পাচ্ছি ম্যাডাম।
না, আমার মনে হচ্ছে ইয়ার প্লাগটা কাজ করছে না, স্পিকারটা। তো এমনি ডাইরেক্ট বলছি তাহলে।
ওকে, হ্যাঁ শিওর, কথা শোনা যাচ্ছে তো?
ঠিক আছে, ওকে।
কুন্তল স্যার, হ্যালো।
হ্যালো বলুন।
তাহলে কি আরম্ভ করে দেওয়া হবে?
গুঞ্জন স্যার আসেনি তো?
আচ্ছা, গুঞ্জন না, বিশ্বাস স্যার আই থিংক।
আচ্ছা, বিশাল স্যার না, 56 হয়েছে অ্যাকচুয়ালি।
ওকে, তো ওয়েট ফর 4 মিনিটস।
হ্যাঁ স্যার, দেবনাথ স্যার একটু দেখুন না রেডি হয়েছে নাকি।
স্যারকে এবার ফোন করুন।
হ্যালো।
হ্যাঁ স্যার।
হ্যালো।
হ্যাঁ স্যার,
গুড মর্নিং।
গুড মর্নিং।
অডিবল?
হ্যাঁ স্যার, অডিবল।
হ্যাঁ, ইয়েস।
এটা নিয়ে না, এটা নিয়ে না, এটা তো স্পিকারটা বাবা বললো কাজ করছে, এখন আর করছে না।
Biplab, can you hear me? Biplab, can you hear me?
Yes,
Dr. Biplab?
yes, ma'am.
So
Good morning,
I'm
ma'am.
on to it. Yeah, good evening.
Okay.
Good evening. So I'm already there. So let
Okay.
your first lecture finish after that, because otherwise
Okay.
Zoom sometimes creates lots of problems. Okay.
Okay, ma'am.
Hello, Papia.
হ্যাঁ, হ্যালো।
Hello, তুমি এখানে? তোমারও লেকচার?
আমার লেকচার কালকে রাত্রি 8টার সময় বিপ্লব শিডিউল করেছে।
কালকে রাত্রি 8টা?
হ্যাঁ, হ্যাঁ, হারিকেন লেকচার।
Vishal sir, you can start now. Just.
Okay. So good morning, one and all. Respected eminent speakers of today's webinar, convener Dr. Biplab Debnath sir, chairman of today's webinar, Professor Dr. Kuntal Hadra sir, patron Professor Dr. Ravindra Debnath sir, faculty members from different colleges, research scholars, my dear students, participants, faculty colleagues, ladies and gentlemen. Once again, a very good morning to one and all. It gives me really immense pleasure to extend a very warm welcome to all of you on behalf of Bharat Technology Ulubedia Howrah. I appreciate all your presence at this very difficult times. We are delighted and honored to host a continuous webinar series, and today is the 4th webinar that we are going to conduct. I, Vishnupada Biswal, Assistant Professor, Department of Pharmacognosy, Bharat Technology, take the opportunity to moderate the today's webinar. First of all, I would like to thank our convener sir for giving me this wonderful opportunity. Now, I would request our convener sir, please say a few words regarding today's webinar. Over to convener Dr. Debnath sir.
Thank you. Very good morning, all delegates. It is an honor and privilege for me to welcome you on behalf of Bharat Technology to this webinar and approach to drug design and overview on COVID-19, which has been organized by Bharat Technology Department of Pharmacy. Bharat Technology online webinar series spread the knowledge on health and pharmaceutical sciences continues to be on roll. We have already completed different seminars, webinars successfully with your blessings and love. Being the convener of the webinar, I, Dr. Biplav Devnath, would like to declare that today is our 4th webinar. I am delighted to welcome all the distinguished participants. I thank the expert from accepting the invitation of Bharat Technology. In particular, I would like to express my gratitude and warm welcome to our eminent speakers, Professor Dr. Papia Mitra Majumdar, Professor, Department of Pharmaceutical Sciences and Technology, BIT Mesra Ranchi, Professor Dr. Jagannath Shau, Principal, Kite School of Pharmacy, UP, India, Professor Dr. Swastika Ganguly, Madam, Professor, Department of Pharmaceutical Sciences and Technology, BIT Mesra. I would like to express my heartily welcome to patron of the program, Professor Ravindra Devnath, Vice President, West Bengal Pharmacy Council, and the Principal, Sir Dr. Kuntal Ajra. I wish to extend my deep appreciation to the Bharat Technology webinar team for their immense help, support, and dedicated efforts to actualize this webinar series. While I can't mention each one Bharat Technology team by name here, I hope that it will be take this is in a personal thank you. Thank you, everyone.
Thank you, sir, for your valuable words. Now, I would like to invite our chairman of today's webinar, Professor Dr. Kuntal Hajra, sir, to say something regarding today's webinar. Over to Hajra, sir.
Good morning, on and all. Honorable patrons of this webinar, today Chairman of Bharat Technology, distinguished speakers, Professor Dr. Papia Mitra Majumdar, Professor Dr. Jagannath Shau, Professor Swastika Ganguly, colleagues, dear students, and all the participants throughout the country, and outside the country also. It gives me an immense pleasure to welcome you all in this webinar. Today, it is our 4th consecutive webinar. We are organizing this series of webinar consistently for the students to gain the information and upgrade their knowledge. Speakers here to spread the knowledge, and we have to extract the best of from this. And as Professor Papia Mitra Majumdar Madam told that yesterday evening only she got this information, and see within short period of times how she is preparing for delivering these lectures. Such a great things, Madam. Welcome you. Please, you give us and enlighten us from your valuable thoughts. Professor Jagannath Sahu, the principal, is a well-known person in this pharmacy field. Sir, Madam Swastika Ganguly, Madam, we are also highly eager to know from 3D regarding 3D QA and the advancement of this drug designing. So, Madam, we are also we are here to listen from your mouth, and I think Madam is the guide of our Vice Principal, sir. We are eagerly waiting to know from your mouth, Madam. I welcome you again, once again, to all the participants, and including Professor Dr. Amalendu Basu, sir. Please, sir, welcome you, sir. Thank you once again. What you, Biswas, sir.
Okay, sir. Thank you, sir, for your inspiring speech. Now it's time to invite our chief patron of today's webinar, Professor Dr. Ravindra Devnath, sir, to say a few words. Devnath, sir, please.
Hello, I'm audible.
Yes, sir. Yes, sir. Continue.
Yes, sir.
Good morning to all of you, all participants present in our lunar seminar. So, seminar is organizing during the lockdown stage. The student, staff, and learned faculty members from all over world they are participating. So this is one kind of a very good achievement because we have to change with the advancement of science and technology. So yesterday, Modi ji declared a new education policy. So new education policy is cope up with a new idea, newer theory, newer ideology, so that the education will be perfectly utilized for the country, for the benefit of the human being. So education is such an important aspect. Now we are not very much aware about the antiviral drugs earlier. We thought, everybody thought that virus is a disease. Within 4 to 7 days it will be eliminated. So that is a corona issue. This corona issue to be dealt with very positively, very sincerely, so that any kind of such type of calamity comes to us, we can fight for this one. So for fight for this one, first of all is knowledge and sincerity. So knowledge is our treasure, knowledge is our bank. So if the knowledge is more powerful, then it can be utilized properly. And we are happy that our Indian people, especially in the Bengal and other states, are so much industrious and so much intelligent that is why there was a proverb is the knowledge capital is Calcutta. So our institute is also located in West Bengal. Many times Professor like Jagannath Sahu is coming, Mr. Ganguly is coming. So it will be a good platform to discuss the all the issues so that a good resolution, good thing can come out to fight with the present situation or future allotment. I once again thanks all of you. You have come across. So of course, virtual meeting. So now virtual meeting can be organized at any time, any place. It is helpful for us. So I think the staff and student professors, they will be utilizing this type of facility. Thank you very much.
Thank you, sir, for your valuable address for all the participants here. Now, it's my privilege to introduce our today's first speaker of this today's webinar, Dr. Papia Mitra Majumdar Madam. Currently, Madam is a professor in pharmacology in the Department of Pharmaceutical Sciences and Technology, BIT Mesra, Ranchi, Jharkhand. Madam had done her B.Pharm and M.Pharm from Jadavpur University, Kolkata, and subsequently had completed her PhD from BIT Mesra, Ranchi. She had guided 13 PhD scholars in her career so far and presently guiding 5 more PhD scholars. Madam had completed successfully sponsored projects which is funded by UGC and AICTE. She is the National Scholarship Holder which is issued by Ministry of Human Resource and Development, MHRD, and also the recipient of UGC Research Award. Madam has more than 140 publications in national and international journals and also published 2 books. Madam is also a member of AICTE Expert Committee and reviewer of a number of journals of national and international repute. Now, I would like to invite today's first speaker of today's webinar, Dr. Papia Mitra Majumdar Madam. Madam, you can continue, Madam. Carry on.
Thank you for a wonderful introduction and Like this COVID-19 situation has brought us very near, though we are sitting all far away, in terms of webinar and lectures. Yesterday evening, around 8 o'clock, I was requested by Dr. Biplab to present a seminar. We had a discussion earlier, but it would be so early, I was not knowing. Anyway, there may be some mistakes from my end, which I think you'll excuse me for that. One problem I'm having is with Zoom. So I had sent the presentation. If you can share it from your end, then that would be fine. Biplab, if you can share the presentation from my end.
Okay.
Yes,
From
ma'am.
your end.
Already shared.
Yeah.
Okay.
Okay. Okay. So put it in the full Zoom mode. Yes. I think I have chosen a very common topic. Everybody knows a lot about diabetes, and that is a very common lifestyle disorder which most of us are facing. Some of us, we know about it, some initially goes unrecognized. So my today's topic of discussion will be neuronal complications associated with diabetes mellitus, an overview. Because lots, I just saw the topic which was given, it was on COVID-19, but since I usually work on the field of diabetes, I thought I'll be saying something about it. Most of it which you may know, some may be new information to you. So let's share. Next slide, please. Oh, so this is my introduction, which has already been given. I don't think I'll be repeating it once again, but sir had said that I had published 2 books. It is not books, it is 2 book chapters. So I would just like to rectify that. Okay, next slide. Next slide, it deals with diabetes mellitus. Now, we all know, starting from the very beginning, it's a progressive metabolic group of progressive metabolic disorders, which is characterized by hyperglycemia, polyuria, polydipsia, polyphagia, etc. Now, what is this metabolic disorder? We can say it is also metabolic syndrome, which actually consists of a cluster of conditions which occur together, and they in turn increase the risk of heart disease, stroke, then type 2 diabetes. And we know that diabetes is such a disease, such a lifestyle disorder, if we do not control it at the very beginning. I think there is some disturbance. Okay. If we do not control it from the very beginning, what can happen is it may lead to, what should I say? It may lead to damaging of most of the organs in the body. Starting, it can start from tip of the root hair till tip of the nails. So what is happening is, we know that there is excess of glucose, or maybe there is deficiency of insulin, which is unable to digest the carbohydrate which is required. All the body organs, they require this carbohydrate. Now we cannot suddenly say, no, I will be on a carb-free diet and I'll not have any of the carbohydrates. I can tell you one thing which had happened, like this cutting of weight. This is very common with girls, ladies. So I had started thinking that I'll stop all carbohydrate diet and go in for fruits and all those things, only vegetables and all those. What had happened was, which I realized after a month, I lost weight, definitely. But thing is that I started forgetting things. Now, what is happening is brain requires glucose. There is another aspect to it. If there is too much of glucose, glucose present, then that is also not desirable. That may cause necrosis. But if there is no glucose available, then what happens is, again, the neuronal cells, the nerves, they start degenerating. So I had chosen this topic. There are a number of complications that occur due to diabetes, but neuronal damage is one such major complication. Okay, next slide. Factors contributing to hyperglycemia. Now, there are three main which we have pinpointed: reduced insulin secretion, decreased glucose utilization, and apart from that, carbohydrate, protein, and fat metabolism are also adversely affected. Now, reduced insulin secretion, which we know that the pancreatic beta cells, they are getting damaged. Once they are getting damaged, what is happening? There is less amount of insulin which is being secreted, and there is less amount of insulin circulating, due to which glucose utilization is not up to the mark. In another case, what may happen is there will be insulin which is secreted up to the normal level. But what can happen is whatever insulin is getting secreted, it is not getting utilized. So that condition, that particular condition is called insulin resistance, due to which type 2 diabetes usually develops. Next slide. In type 1, there are different types of diabetes. Type 1, type 2, you know, the genetically modified ones, all those things. Gestational, the commonest one, the first one is type 1, which we all know. It's also called juvenile diabetes or insulin dependent diabetes. And there is cell destruction, which leads to absolute insulin deficiency, which I just said. Insulin is not getting secreted. And that may be idiopathic because the cause may be unknown, or it may be immune mediated. So it is an autoimmune condition in which the insulin producing beta cells are destroyed, and hence the body loses its ability to produce insulin. And this particular type usually affects mostly 5% of the population. Next one. Type 2. Type 2 diabetes. In the next slide, we are having type 2 diabetes. If that can be changed. Yes. Type 2 diabetes, it is non-insulin dependent, NIDDM, and it occurs when the peripheral tissues sensitivity is compromised. As I said, there is insulin resistance. There is lots of circulating insulin, but the problem is that the body is unable to utilize that insulin. And that is why what happens is PP sugar, which we usually talk of fasting blood sugar and PP sugar. So what we do is in PP sugar estimation, just after 2 hours, we estimate the blood glucose level. Now in that, which we are actually checking the insulin resistance, if any, that is occurring. Okay. So this defect in insulin sensitivity and secretion causes glucose to accumulate, and it is the commonest form, which accounts for around 90 to 95% of the NIDDM disease in the population. And the risk factors associated are family history, genetic factors, obesity, high BP, high cholesterol, etc. So that is why we always say that diabetes is a lifestyle disorder. If you are having obesity, you are more prone to diabetes, and vice versa. If you are having blood pressure or you are having high cholesterol level, the chances may be that you can develop diabetes at a later stage if it remains uncontrolled. And moreover, if you're having a family history genetically, then the chances increase manifold. The next type, which doesn't occur, if you can change the slide, please. the next type is gestational diabetes. Now, gestational diabetes, obviously it will be occurring in women only during pregnancy. And maybe these particular women, they were never diagnosed of diabetes earlier, but they exhibit high blood glucose level during pregnancy. And in some cases, it has been found that after the pregnancy, after childbirth, the condition subsides. So that is a specific condition which can occur at that point of time. And this is associated with glucose intolerance, which occurs during pregnancy at an older age, obesity, and with family history of diabetes. And in this particular case, what happens is the pregnant lady is unable to secrete enough insulin, which is required during pregnancy. So the, what should I say, the utility of insulin enhances during pregnancy, but secretion or production of insulin does not increase. That may be a genetic disorder, or that may be a very like a physiological disorder, and thus gestational diabetes occurs at that point of time. Next slide. Next slide, we come to the defects, genetic defects, like maturity onset diabetes of youth, MODY. So MODY, not MODI. So it is associated with impaired insulin secretion with minimal or no insulin resistance. So it is a, what should I say, it's a condition where there is a genetic inability by the person to convert proinsulin to insulin. What is proinsulin? It is a building block. We know it is the precursor or the building block of insulin. And the three chains are getting converted into two chains with the help of different enzymes. And that is linked by the disulfide bond. So this conversion does not take place, and there is increased amount of circulating proinsulin, which causes this condition of diabetes. And it has been found that conditions like type 2 diabetes or chronic renal failure, they may increase the proinsulin value, which in turn may cause this MODY defect. And there are different types, chromosomes, depending upon the different chromosomes that are being involved, like MODY3, MODY2, 1, that list is given over here, and also mitochondrial DNA. Next, we come to the next slide, genetic defects in insulin action. Now, genetic defects in insulin action, there are a few names which I have mentioned over here. Type A insulin resistance, then leprechaunism, Rabson-Mendenhall syndrome, and lipoatrophic diabetes. Now, these terms are not that common, and we do not hear of them very often. So, like, just I'll give you one line regarding them. What are they? This type A insulin resistance is a rare form of disorder where severe insulin resistance occurs and the body does not respond properly to the insulin. In leprechaunism, what happens is it's a rare disorder which is characterized by abnormal resistance to insulin, showing growth delay and abnormalities affecting the endocrine system. Now, the third one, Rabson syndrome. Here, this thing is somewhat similar to leprechaunism, but here, what this disorder is occurring due to mutation. Over there, it was due to abnormal resistance. Second one was due to abnormal resistance, but this one is occurring due to mutation. And lipoatrophic diabetes, here there is absence of adipose tissue from birth. Adipose tissues are required, we know that. It is not only it's fat which is getting deposited, and it has got numerous benefits. It does not only increase your weight anyway. So absence of adipose tissue from birth, along with insulin resistance and glucose intolerance. So all these factors, they contribute to lipoatrophic diabetes. Now, pre-diabetes. Pre-diabetes is a condition where the blood sugar level is higher than normal, but it cannot be classified as type 2 diabetes. And without intervention, the pre-diabetes may become type 2 diabetes. That is a pre-diabetes condition. I'll just give you an example. So we had studied, when we in B Farms, we had studied that 80 to 120 mg per deciliter is a normal blood sugar level, blood glucose level. But sometimes nowadays we see, when we go through the net, it is around 80 to 110. So does that mean when it is 120 you become diabetic? No, it is not like that. Sometimes what happens is a person may be 140 mg per deciliter, but still the person is neither pre-diabetic nor diabetic, because the genetic makeup of people vary from one person to another person, and that can be considered as the new normal, 140 mg per deciliter. But definitely, when it is 180 mg per deciliter, there is big reason to worry about it, and that can be considered as the pre-diabetic condition. Like when we do the animal studies, what we do, when we are inducing diabetic condition in animals, we administer streptozotocin, and then we see whether after 72 hours, for a period of at least 15 days, but what happens is naturally 15 days we cannot keep the animal, so till 7 days, whether the animal is showing high blood sugar level above 200 mg per deciliter consistently, then we say that the animal is diabetic. But suppose it shoots up, and then it comes down to 130 mg or 140 mg, and it stays like that till maybe 7 or 14 days, we don't say that it is diabetic at that time. Okay, the next one. Other specific types. Yes, other specific types. Diabetes secondary to or associated with pancreatic disease, drug or chemical exposure, insulin receptor abnormalities. And diabetes may occur due to pancreatic exocrine disease as well, because of destruction of the majority of the pancreatic islets. So we see that as a result, as secondary to certain diseases, diabetes may develop, which I had already said before. So these are some where we can have, the patient can show diabetic conditions. For example, pancreatitis, pancreatectomy. I think students have already, when the master degree students, they do this, like when you are screening a particular drug for anti-diabetic action, we usually in laboratory scale, we do it with streptozotocin. Earlier, we used to do it with alloxan, but there is one particular methodology, that is pancreatectomy in dogs. If you go through Vogel, you can find that there is a methodology of pancreatectomy in dogs, definitely partial pancreatectomy, which causes this particular condition, diabetic condition precipitates. Apart from that, you have neoplasia, then cystic fibrosis, etc., which can contribute to occurrence of diabetes as a secondary condition. There may be acromegaly. Acromegaly, you know, there is abnormal growth of hands and feet because the growth hormone production is it is overproduced. Then you have Cushing syndrome, where there is overproduction of corticosteroids by the adrenal cortex. Then you have glucagonoma, pheochromocytoma, hyperthyroidism, all these things. So they tend to cause secondary complications, diabetes being one of them. Okay, next slide. Now we go to the long-term complications of diabetes. In long-term complications, persistent long-term diabetes increases the risk of further complications that typically develop after many years. Now, there are people, what they do is, once they are diagnosed of hyperglycemia, they say, oh, I'm just having hyperglycemia. It doesn't matter. I can have a number of sweets and fried things, and nothing is going to happen because I'm very young. So my metabolism, we tend to depend on Google. Google becomes our doctor, and textbooks we have forgotten. So we say that this is going to happen, nothing is going to happen, or maybe I can walk maybe 10-15 minutes or on the treadmill and I'll be fine. Or maybe some jari booty we tend to take, like some leaves or kisi baba ka churan or something, and we are just fine. But the case is not like that. When it's a lifestyle disorder, you will have to change the lifestyle. Somebody brings mutton and, oh, okay, only one day I'm having mutton, nothing is going to happen. That is not the case. That doesn't happen because it is not one day. Definitely one day if you have, nothing is going to happen. But if this one day enhances to 30 days, then definitely something is going to happen. And so this diabetes, the lifestyle needs to be changed. Proper medication is to be taken from after taking proper advice from the doctor. Otherwise, what happens is, if the complications, if the condition remains like that, then complications develop. After maybe 2 to 5 years, you can see that eyes get affected, cataract. A person at around 40-45 years of age is having cataract. Why? Because he was having diabetes and that was not treated. Sometimes off and on he used to take the medicine, and sometimes he used to become his own doctor. So things worsened. So these conditions are retinopathy. These are two types, microvascular and macrovascular. Microvascular means the minor vessels get affected, and macrovascular, the larger vessels get affected. So they are retinopathy, nephropathy, neuropathy, diabetic foot, which will come under microvascular complications, and macrovascular, definitely heart disease, coronary heart disease, then stroke, peripheral arterial disease. These things occur. Now, I was going through your participants who are there, and I found some of my students who have already worked with me in these microvascular and macrovascular conditions. They are present, so they can relate better. They know what sort of things usually happen. Okay, so this is a pictographical representation. Next slide, please. Pictographical representation of diabetic complications. We are having this micro and macrovascular, and eye, kidney, nerves, etc. They are getting affected. And here the brain is getting affected, due to which there is cerebrovascular disease, heart disease, and the extremities. Because we have heard that from diabetes, the extremities, there is gangrene occurring. What is the first sign? Like, we usually do not go for a blood check every month, do we? We don't. So the first sign is like when there is a cut in the body and that doesn't heal. So you know that something must be wrong. And because when there is a minor cut, it heals very fast. It doesn't heal. So then definitely there is something wrong, and that condition, that wrong condition, in all probability may be high blood sugar. Apart from that, ulcers, all these things, they do not heal. And you'll find that the person is excessively hungry, excessively thirsty, which is not normal. Okay. So now we come to these neuronal complications of diabetes. And in this presentation, next slide, please. In this presentation, we have divided it into two categories, diabetic neuropathy and cognitive impairment. I had told you just in the beginning of my presentation that what happens is in neuropathy, when you stop taking glucose or any form of carbohydrate, you tend to forget. So that is cognitive impairment. You cannot remember. So your brain cells, your nerve cells are getting affected. In neuropathy, what will happen? The tips of the fingers, all those things, there will be a numbness. There will be a tingling sensation. Okay. Now, next we come to the next slide, that is diabetic neuropathy. It's a family of nerve disorders which is caused by diabetes, and chronic diabetes may cause this particular condition. It may be asymptomatic, or there may be certain symptoms like pain, tingling, or numbness, and loss of feeling in the hands, arms, legs. You can feel that it becomes numb. Then the highest rate of occurrence of diabetic neuropathy are amongst people who are diabetic for at least 25 years. So diabetic neuropathy condition develops a little late. First, you'll have this peripheral neuropathic conditions, and then you will have cognitive impairments and all those things. And finally, entire nerve damage will occur much later on. Next, causes of diabetic neuropathy. There are various factors, metabolic factors, where high glucose level, long duration of diabetes, abnormal blood fat levels, low insulin levels. They are the factors. The neurovascular, it causes damage to the blood vessels that carry oxygen and nutrients to nerves. Autoimmune factors causes inflammation in nerves. Autoimmune means the body's immune system develops the antibodies against the body itself. So antibodies of that are developed, that they will work against the body, and that will cause inflammation. Then you have mechanical injury to nerves, like the carpal tunnel syndrome. Then you have inherited factors or genetic predisposition, and lifestyle factors. Smoking, alcohol use, definitely these will cause diabetic neuropathy. The next slide, the general symptoms. The general symptoms which are associated are numbness, tingling or pain in toes, which I had just talked about. Wasting of the muscles of feet and hands, that you will find. Muscle wasting occurs. Though the person becomes excessively hungry, there is never a feeling of satisfaction, but the muscles tend to degenerate. Muscles will waste away. Then there is indigestion, nausea, vomiting, etc., and all those things. Dizziness due to drop in blood pressure after standing from after you stand suddenly from a sitting position, which we sometimes say it is due to orthostatic hypotension. Then you have erectile dysfunction in men and vaginal dryness in females, and there are problems of urination. Now we come to the types of, next slide, types of diabetic neuropathies. Here, I don't think anything is visible, but I'll just tell you. Here, there are different types, 4 different types which has been pinpointed: autonomic neuropathy, focal neuropathy, proximal neuropathy, and peripheral neuropathy. Now, each of them we'll be discussing, but just briefly telling you, all of them, they are affecting the nerves, but definitely they are affecting the nerves at different regions in the body. Next one, next slide, peripheral neuropathy. Here, the body parts which are affected are toes, feet, legs, hands, arms, the peripheral parts definitely, and there is sharp pain, burning sensation, numbness, tingling sensation, loss of feeling, hypersensitivity, etc. the next slide, autonomic neuropathy. Here, there is the affected areas are heart and blood vessels, digestive system, urinary tracts, sex organs, sweat glands, eyes, lungs. And here are a whole lot of symptoms which can occur, which initially you may not be able to distinguish. That is a problem. So nausea, vomiting, like in pharmacology, all drugs are having nausea, vomiting. So definitely nausea, vomiting is there. You do not know whether it is just due to some side effect or due to maybe this autonomic neuropathy which is occurring, dizziness, faintness, erectile dysfunction, incontinence of urine, etc. Next is the third one which we are talking about is proximal neuropathy. And the next slide, proximal neuropathy, and the affected areas are the proximal areas like hips, thighs, buttocks, legs, etc. And there is extreme pain and weakness in the affected areas with muscle wasting. There is inability to go from a sitting to standing position without help. Now, this is a serious condition because the pain becomes unbearable and the mobility of the person gets hampered. Focal neuropathy, the next slide, focal neuropathy, the affected areas are head, torso, legs. And you have certain specific symptoms like double vision, eye pain, paralysis on one side of the face, that's called the Bell's palsy. Then severe pain in a certain area like the lower back or legs, and chest or belly pain. Now we have the mechanisms which are involved. Now all these mechanisms, I think most of us are teachers over here, so everybody is quite familiar. Polyol pathway activation, protein kinase C activation, oxidative stress, then ADP polymerase activation, then AGE formation, that is advanced glycation end product formation, and essential fatty acid abnormalities. So all these, they are affecting the nerves. Ultimately, it affects the nerves. So I have given that in a flow chart. In the next slide, we have a schematic representation of the mechanisms involved. In diabetic neuropathy, you can see over here that hyperglycemia is the condition, excess of blood glucose. It is causing increased extracellular protein glycation, increased intracellular glucose in nerves and vascular tissue, microvascular vasoconstriction, capillary basement membrane thickening, endothelial hyperplasia, hemorrhagic abnormalities, and they in turn are causing certain biochemical disruptions which may lead to either of them, like AGE formation is there, and finally there is oxidative stress. Then RAGE formation is there. There is a receptors for AGE. RAGE activation is there, and that leads to oxidative stress. Then you have sugar plus ROS, that is the reactive oxygen species. They act with sugar and form carbonyls, which in turn with proteins and lipids causes glycooxidation products, which leads to oxidative stress. Then you have mitochondrial dysfunction occurring from hyperglycemia. There is increased intracellular glucose, and that leads to increased glycolysis and TCA activity, which causes mitochondrial dysfunction, and superoxide formation is enhanced, causing oxidative stress. So somehow or the other, we see that oxidative stress is developed, and that leads to AGE, advanced glycation end product formations, protein kinase C activation, polyol pathway flux, and that leads to nerve dysfunction and death. You can see this flow chart, which mentions that there are different pathways which ultimately come and merge and cause the nerve dysfunction and death. we come to the diagnostic test. Okay, we come to the diagnostic test. Here we have physical examination, BP, heart rate, etc. Then we have reflex studies, temperature, light to touch, foot examinations, then nerve conduction studies, etc. Next, we have diabetes-induced cognitive impairment. Here, besides neuropathy, another consequence of nerve damage in the CNS is cognitive impairment. We just mentioned earlier that the person tends to forget. Both type 1 and type 2 diabetes have been associated with reduced performance on numerous domains of cognitive function. Severe diabetes, along with poorly controlled blood sugar, can damage nerve cells in the brain and lead to cognitive impairment. Hyperglycemia, vascular disease, hypoglycemia, and insulin resistance, they all play significant roles in cognitive impairment. Now, we have a tendency, when we forget something, the first conclusion we draw is, I'm having Alzheimer's disease. I'm forgetting. I'm having Alzheimer's. It is not like that. Or maybe when we are doing certain experimentations, we tend to give a big name to it. Alzheimer's disease, study of Alzheimer's disease in animals, and so on and so forth. But when an animal has cognitive impairment, or when a person tends to forget, that does not mean that Alzheimer's disease has occurred. That may be a precursor. We can say it can be a stepping stone to Alzheimer's if left untreated, or if the lifestyle is not managed properly. I was forgetting things when I had stopped carbohydrate, but once I started again the carbohydrate diet, this is reversible. So immediately, because damage was not done, if the irreversible damage of the neurons occur in the brain, then only we say that Alzheimer's has occurred due to it. Okay, next slide. Onset of cognitive impairment has been found to occur early in patients with type 1, and the most common cognitive defects identified in patients with type 1 diabetes are slowing of information processing speed and worsening of the psychomotor efficiency. Doing any reflexes, they tend to tone down, they become dumber, we say. Or maybe like when we are giving a speech, we forget what the next line we were thinking of, we were supposed to say, and we go on doing. I think everybody has faced this problem, but that does not mean we are having cognitive dysfunction. When this condition becomes worse, then we say that there is cognitive dysfunction occurring. Now, a case study I've given over here. Next slide. I've given a case study of DCCT, which showed that those patients with type 1 diabetes with a time-weighted mean glycated hemoglobin HbA1c less than 7.4% performed significantly better on tests of motor speed and psychomotor efficiency than those subjects whose time-weighted mean HbA1c was greater than 8. Now we know that when we are doing anti-diabetic experiments, one thing which we all should be doing is glycosylated hemoglobin estimation or glycated hemoglobin estimation. So what is happening in this is that hemoglobin or the RBC, in RBC there is attachment of glucose, okay? And these RBCs, they remain alive for 3 months. We know 90 days they remain alive, 120 days they remain alive. For 3 to 4 months they remain alive. And as long as they are there, the HbA1c level will not vary. Because once the glucose is getting attached, you cannot say now the glucose is reduced because I'm taking drug. Once that RBC gets damaged, dies out, newer ones are born, then if we check, we can say that glycosylated hemoglobin level is less than 7.4% or whatever. Like less than 7.4% is optimum. That is necessary for healthy lifestyle, and more than 7.5 or more than 8 rather, it is dangerous, because that shows that diabetic condition is still there and it has worsened. Then we come to the next one, cognitive domains negatively affected by type 1. Next slide, yes. Slowing of information processing, we have just discussed psychomotor efficiency, attention, memory, etc. Problem solving or attitude, then motor speed, vocabulary, intelligence, visual construction, visual perception. Perceptions, they decrease. Motor strength, mental flexibility, executive function, they decrease. Now you see that there are a number of them which are having the star asterisk mentioned, and that is particularly having strong supporting data. We are having literatures for that. Next slide. Glycemic control appears to play a role in determining the degree of cognitive dysfunction detected in patients with type 2 diabetes, and impaired glucose tolerance without diabetes is also a risk factor for cognitive dysfunction. So when there is impaired glucose tolerance, glucose can't be tolerated, there is impairment, but the person is not showing diabetes as such, then also there is a risk for dysfunction, cognitive dysfunction, forgetfulness. So in the next slide, I have given another case study. It is a population of post-menopausal women, and it was found that those with HbA1c more than 7 had a 4-fold increase in developing mild cognitive impairment. So you know why it is absolutely essential to control that HbA1c level, and that is tested once every 3 months. Every month you do not check HbA1c because that is not going to change, because as long as those RBCs remain, this is not going to change. Next one, we had already said about type 1, now it is type 2. Am I running short of time, Biplab? Or I can continue a little bit more?
Yes, ma'am, continue.
Okay. Okay, so the cognitive domains which are negatively affected are memory, psychomotor speed, executive function, all these things, verbal fluency, delayed recall, etc. Next, we are having repetitive, now hypoglycemia. Now I was talking about hyperglycemia. Next slide. Hypoglycemia and cognitive dysfunction. It is not only that when you're having hyperglycemia, you tend to forget. When there is hypoglycemia also, there is cognitive dysfunction occurring. Repetitive episodes of moderate to severe hypoglycemia have been implicated as a possible etiology of cognitive dysfunction in diabetes. Patients with type 1 at less than 5 years of age have more severe and frequent hypoglycemic episodes rather than those diagnosed greater than 5 years. So children below 5 years get affected much more with hypoglycemic episodes than hyperglycemic episodes. And in acute hypoglycemic episodes, it has been shown that performance on immediate verbal or visual memory, working memory, delayed memory, visuomotor skills, visual spatial skills, and global cognitive dysfunction are all impaired. Now, in the next slide, I've given you the causes of diabetes-induced cognitive impairment. The cognitive dysfunction in diabetes, it can be caused due to insulin resistance, microvascular complications, macrovascular complications, hypoglycemia also, absence of apoepsilon 4 allele, and absence of C-peptides. The next slide, I'll not go on into the details of the pathological mechanisms, just mentioning, as we had mentioned earlier, the in diabetic neuropathy, hyperglycemia leads to polyol pathway activation, then advanced glycation end product formation, increased formation, then diacyl glycerol activation of protein kinase C, and increased glucose shunting in hexosamine pathway. next slide, we have chitin production, and there is possible role of hexosamine pathway in this chitin production, cerebral chitin production. And if hyperglycemia from diabetes shunts glucose towards the production of chitin, it is possible that the accumulation of this molecule could contribute to abnormalities in cognition. Next one, oxidative stress, which we had already mentioned, which leads to end organ damage, then neurotransmitter function, which leads to cognitive dysfunction. It has been observed that in diabetic models may also contribute to cognitive dysfunction. And preclinical diabetic models showed impairment of long-term potentiation, defined as activity-dependent prolonged enhancement of synaptic strength. That is, in neurons rich in NMDA, which could contribute to learning deficit. So hypoglycemia, I will skip this slide. Hypoglycemia in animal models, which we usually do, and it has been found it leads to a flat EEG reading. Okay. Next, we come to miscellaneous autopsy studies on patients with long-standing type 1 diabetes have shown changes to vascular diseases and also potentiate ischemic damages by lactate accumulation, increases and lack of peptide, C-peptide. Okay, so the diagnostic tests, next slide, diagnostic tests. Flash electroretinography, if you can have, yes. Brainstem auditory evoked potentials, MRI, functional MRI, single PET scans, photon emission, computer tomography, etc. Now, next slide is quite interesting because a new terminology we have not framed anything. It is the literature that has framed it, and it is type 3 diabetes mellitus. No, it is nothing, but it is actually Alzheimer's disease stemming out of diabetes. This term suggests that Alzheimer's disease represents a form of diabetes that selectively involves the brain and has molecular and biochemical features that overlap with type 1 and type 2. Insulin resistance, long recognized as a factor contributing to the onset of type 2, may play a role in the pathogenesis of Alzheimer's disease. And impairment in central cholinergic activity is believed to contribute to Alzheimer's disease. In a study, rats with induced diabetes, STZ-induced diabetes, have a decrease in the production and release of acetylcholine as compared to control rats. So this has been found. We have done this particular experiment in our laboratories, and we have found that STZ-induced rats have got a decreased production and release of acetylcholine hormone, acetylcholine neurotransmitter, as compared to the control animals, and that accounts for memory impairment, cognitive impairment, which ultimately leads to Alzheimer's disease, which we here tell or denote as type 3. Next slide. The advanced AD is associated with reduced level of insulin and insulin-like growth factors, polypeptide and receptor genes in the brain. And this insulin resistance promotes the formation of senile plaque. So what is happening is, due to insulin resistance, senile plaques are being formed. And we know that formation of senile plaque is the characteristic feature of development of Alzheimer's disease. Beta amyloid is formed from the cleavage of amyloid precursor protein produced in neurons by the enzymes beta and C secretase. And beta amyloid is eventually degraded by the insulin degrading system. Next one. Research shows that, next slide. Research shows that insulin and insulin resistance can affect the metabolism of APP and beta amyloid. And insulin resistance seems to be a significant risk factor for Alzheimer's. So now here we are correlating type 3, which we had said. Now, this insulin resistance is there as a part of diabetic condition, and that finally leads to cognitive impairment, and in the next stage, it causes formation of senile plaques and causes Alzheimer's disease. So next one, PPAR gamma agonists may affect the pathophysiology, and they are found to be beneficial in the treatment of Alzheimer's disease. Hence, evidences have led to the coining of the term type 3 diabetes mellitus for Alzheimer's disease. Now, we are seeing it in literature that since it is stemming from occurrence of diabetes as a long-term complication of diabetes, there is neuronal damage, formation of senile plaques, etc. The terminology type 3 diabetes is becoming more and more popular. So lastly, in my last slide, I would like to summarize our today's discussion: hyperglycemia, hypoglycemia, and insulin resistance. And in hyperglycemia, we are having microvascular dysfunction, polyol pathway flux, and AGE formation, which leads to oxidative stress, and finally nerve dysfunction and death. And that causes, when there is nerve dysfunction, it causes diabetic neuropathy and cognitive impairment, both. In case of hypoglycemia, it will eventually lead to neuronal necrosis and cognitive impairment, but it will not cause diabetic neuropathy. Diabetic neuropathy will be caused by hyperglycemia alone. And when there is insulin resistance, there will be reduced cerebral glucose metabolism and disruption of hypothalamic pituitary adrenal axis, formation of senile plaques. Now, all these will lead to cognitive impairment, and formation of senile plaques will ultimately lead to Alzheimer's disease. So we can say that this neuronal damage will be coming under these three factors, three categories. Like there will be diabetic neuropathy, there will be cognitive impairment, and there will be eventually, if left untreated, will lead to Alzheimer's disease. So that much for today's discussion, but discussion never ends. There are a number of more studies which are going on and which we are carrying out in our laboratories, and we are trying to pinpoint on certain mechanisms leading to type 3 diabetes, which is stemming out of Alzheimer's. So some references, and thank you all for giving me a patient hearing. Thank you.
Thank you, madam. Thank you, madam, once again for your wonderful and informative session. So I'm not going to detail about your topic. So now we'll take a few questions from the participant sides, madam. So here is a question from our patron, sir, Professor Dr. Ravindra Devnath, sir. So what is the relationship between diabetes and Parkinsonism?
Actually, right now, we can say that Parkinsonism is a neurological disorder. Now, when we were talking about this, we said that diabetes, if left untreated, or maybe like for 25 years, after 25, around 20 to 25 years, it develops diabetic neuropathy. Now, when there is neuropathy, a tremendous level of neuropathy, neuronal damage, nerve damage, what is going to happen? It can precipitate the condition of Parkinsonism. So ultimately, what is happening is hyperglycemia. Hyperglycemia is causing damage of the nerve cells. And due to this damage of the nerve cells, finally, the person may develop Parkinsonism, because we know that diabetes is the root cause for most diseases, and it causes damage from the root hair root to the tip of the nail, which I said in my first thing. And gradually, each and every organ gets damaged. So that is it.
Okay, thank you, madam. So another question from Dr. Amalendu Basu, sir. For a diabetic patient, doctors are asking for test of fasting and PP sugar or HbA1c. So which test will be better for knowing the diabetic condition for a patient?
Both are required. As sir, I told you that fasting sugar is definitely required to know how much amount of insulin is getting secreted. So that once that amount of insulin is getting secreted and that is getting utilized, we can say we can get the results of the fasting sugar. But in case of PP sugar, what is happening is insulin may be getting secreted. So maybe fasting sugar level is not showing that much high, but insulin is getting secreted. But what is happening is that insulin is remaining in circulation itself. And after 2 hours, when you are checking your blood glucose level, you find that it's quite high because your body has got insulin resistance, and that insulin is not getting utilized. It is not getting utilized by the body to digest the glucose which you have taken. So to exactly know the condition of diabetes, actually fasting and PP should be known. Apart from that, HbA1c, glycosylated hemoglobin level, needs to be known because that is the confirmatory test for knowing whether diabetic condition is there or not.
Okay, thank you, madam. So there are a lot of questions from participant side. So due to lack of time or shortage of time, so this is my honest request to all the participants, please send your questions to madam's email ID so that madam can clarify all your questions. Once again, I'm sorry for that. Okay, madam.
No, definitely. I'll be very glad to get the questions because in the process, actually learning is a two-way process. So we'll be learning. I'll be learning from that.
Okay, madam. They will be sending to your email ID. Please clarify it.
Definitely. Okay. Yes.
Thank you, madam.
Okay. Thank you so much.
Please, madam, be with us. So our second session will be starting. So straight away, I'm going to start our second session. Before that, it's my privilege and I'm very much proud to introduce my guru and mentor, Professor Dr. Jagannath Sahu sir. So here, I really feel proud to introduce about Professor Dr. Jagannath Sahu sir. Sir has completed his M.Pharm from BITS Pilani and PhD from Biju Patnaik University of Technology, Odisha. Sir is currently working as Principal, Kayet School of Pharmacy, Ghaziabad, Uttar Pradesh. Sir has an overall teaching and research experience of 28 years and guided 65 project students. Sahu sir has published around 30 research papers in various international and national journals. And sir has filed 1 patent and published 3 books. Sir holds life membership in various professional bodies like IST, APTI, ISTP, and sir is the first president of APTI Odisha branch. Sir has acted as mentor in INSPIRE program, which is sponsored by Department of Science and Technology, that is DST, and various faculty development programs. His research of interest is formulation development, stability studies, novel drug delivery system. And sir is the mentor of Change of Kendriya Vidyalaya for Atal Tinkering Lab, which is nominated by Niti Aayog, Government of India. And sir is the member of IAEC, Institute of Animal Ethical Committee of 9 organizations, which is appointed by CPCSEA, Ministry of Environment, Forest and Climate Change, coming under Government of India Animal Welfare Division. So now I would like to invite Professor Dr. Jagannath Sahu sir to start with his magical and mesmerizing speech. Over to Jagannath Sahu sir. Please, sir, continue.
Yeah, thank you, Dr. Vishnu Vishwal, for your nice introduction. And really, the morning and the day will be too good with your, wonderful introduction. And I'm very much thankful to Bharat Technology also for inviting for this webinar. And I'm very much thankful to Dr. R. Debnath sir. I met him in Bhubaneswar several times. And my special thanks goes to Dr. Biplab Debnath sir. And today the session was started with Dr. Papia madam, and which was a wonderful session. It shows that the days will be too good for all of us. And without wasting the time, let me share the screen. My topic will be how to invest the time during COVID-19. So I hope is it visible? Can you please update?
Please, Goranga, sir.
Is it visible, sir?
Yes, sir, it is visible.
Yeah.
Visible.
Thank you, sir. And probably I got to know that Dr. Amlen Basu sir is there in the this team.
Yes, sir.
And
Yes,
yeah, actually, he's my teacher. And today, I feel very proud of myself that I got an opportunity to present myself, being a teacher, being a student in front of a great teacher. And usually in my mind, every student's mind, the best teachers are remembered forever. And he's one of my best teacher to whom I remembered forever. Sir, thank you, sir, for listening to me, to listen to me. So my topic will be that proper utilization of time. And I'll just go through the online resources during COVID-19. And especially it will be for pharmacy students, what are the online resources are available. But before to that, just let me explain the
yes,
what
sir.
is the time management skill that every student, every professional, they should understand and they should develop this time management skill. So this,
Hello.
yeah. Is it audible, sir?
Now it is audible. Continue.
Yeah. So this every one of us being a professional and those who are going to be professional also, that we must learn the time management skill. First of all, in that whenever we are planning for time management, that the first one is the goal setting. What is my goal for today? What is the goal for me for tomorrow? What is the goal for week? What is the goal for my month and my future? So this is a very big, and please, start dreaming your goal. If you don't dream, then obviously the, failure, the failure of every person is because lack of good dream, lack of good goal. Then we have to prioritize our work, what we should do first, and what we can
meeting idea.
What we can do later on. Then we have to go for planning and we have to go for scheduling. So once planning, proper planning helps us to stick to my programs, to stick to my time management. If I don't have any planning, if I go haphazardly, the chances of success is very less. And the failure, people say that failure is the pillar of success, but at present the failure may make us very troubleshooting. We may not get a second chance to recover ourselves. So there should be a proper planning, and there should be proper labeling, also scheduling. So once the skills are mastered, the individuals will find that they are more efficient and organized, resulting in an easier and happier life. You see, finally, we want to remain happy. And to remain happy, it is very essential to make our work easy. Without that, it is never possible to remain happy. And how we can make our work easy? Now, if we ask that around 100 people, that how many of them are happy with their work, I think in India, 90% of the people, they say that they are not happy with their work. It may be because of their skill. I don't say that there will be no hurdles. Hurdles will be there, but it may be because of the proper time management skill. if I understand that what the time should be spent for what, then I can get a very the work easily it can be done. And because I have learned how to do it easily, so I'll have a happier life. So quickly, just it's not changing now. Yeah. What are the tips for better management? First of all, every one of us, we should create a daily plan. And this daily plan supposed to be prepared one day before, that means before going to the bed. That is the best time to make your plan for tomorrow. And whenever you are making a plan, please keep a good time for each task. You can use a calendar or an organizer. All of you are acquainted with this organizer. And all of us, we must know what is my deadline and when I supposed to complete. Then one of the most, art we must learn, this is we must have to learn to say no. If we have never learned to say no, then it will be really very, very painful and always will be in stress. So for example, at present I'm engaged in some important work. If somebody else, my boss, usually, we try to satisfy our boss. And here, if my boss is giving some other work,
Sir, not audible, sir. Please. Hello. Hello, Gorangu sir.
Yes, sir. I think Jagannath Sausa has been lost their connected, sir.
Okay.
I think some network issue is present from
Okay.
their end, sir. Just wait some minute if he joined
Okay.
again.
Otherwise, third speaker will start.
No, now came, sir.
No, so sir is coming. Jagannath Sausa sir is coming.
Okay.
Dr. Biplab? Dr. Biplab,
Yeah.
please, can I talk to you?
Yes, ma'am.
Biplab sir.
Yes, ma'am.
I do not understand. Till yesterday, it was there that there were to be 2 lectures, and now I have got a meeting at 12. I don't know how to accommodate you this lecture today.
Okay,
You
Sau sir, continue.
like this in
Yeah,
an
yeah.
unplanned way. Sorry. I'm sorry to say.
Okay. So this is, we must have to learn to say no. And please make your target very early. Give a good
Please share a
focus.
screen. Sir.
Give,
बोल बाल
very carefully. Then only, like, if you change your focus time to time, it will be very difficult to complete the work on time. So block out the distractions, like, nowadays, all of us,
Sir, share
we
the
are,
screen, sir. Sir, hello.
sorry? Okay. Just 1 minute, sir, 1 minute. Yeah.
Okay.
Sorry, sir. Actually,
No, no,
due
no.
to
Continue, sir.
yeah.
No problem.
So please, all of that we must learn to focus in one work only. God has created our brain not to. We cannot do 2-3 works simultaneously. Those who say that I can do 2-3 works simultaneously, I hope it is wrong, or the God has made him very specially that he can focus clearly for other works. So block out the distraction means here, most of us, the youngsters, it is especially for the youngsters, spending time with WhatsApp, Facebook, chatting with your friends. They will never be helpful for building up your career. So track your time spent, and the tracking of your time spent, it has to be done in the night time. Whatever to do, in night time you have prepared for the tomorrow's, and today you have to track the time, the way you have planned, uh, whether there is any deviations or not. So eliminate from there, whenever you will track your time, then you will know that why there is a whether there is a wastage of the time or not. If at all there is a wastage of the time, then eliminate your time wasters. And whenever, first point, that create your daily plan and track your time spent. This has to match. If it is not matching in the beginning, it will never match. But later on, when you become, whenever you will be used to it and to the similar work, probably this one will match. But whenever you are engaged in some other work or a new work, it may not match. So don't worry about that. If you are not wasting your time, if you are wasting your time, then it will, you have to find a way to eliminate your time wasters. Okay. Who is wasting your time, how it is getting wasted, that you have to find out. And once you find out the problem, it is not a big task to have the solution. Okay. Then whenever you have planned it and there is a deviation, then you have to find out what are the deviations. So once you make the deviations, certainly no one can stop you to be a successful man. So that is what this planner actually, in this slide, the take home tip is that first we have to learn to create the daily plan. The second one is that track your time spent. Then please find out the deviations. So this is the general tip for the better time management. Now, just I'll talk about I don't know what is the problem with this. The slide is not changing. Yeah. So this is especially for the pharmacy students. I'll talk on online resources for the students. I have classified as per the whether you are in first year or second year or third year or fourth year. As I told you, like in COVID-19, we got a pandemic, but it has taught us many things. And the first thing it has taught us that, all of us, we become technical savvy. All of us, we have learned how to use this platform. And this platform, today we are sitting around 63 people. Just before pandemic in the month of March, it was very unknown to everyone. So now during this time, we have learned this one. And this is a wonderful platform. By sitting at home, we can connect to the people of all over the world. And today, it's a very big challenge for the teachers, because, today what I'm teaching in the class, tomorrow the student, the student is having, or the student must have come to the class with a wonderful preparation from the online sources. So, just simply, this is a guideline only, that for first year student, what I can suggest, because this is the Coursera course, I am not a advertiser for the Coursera course, but even I have done during this COVID-19 period, just to update my knowledge. So here in first year, as I told you, like think again how to understand the arguments. So this is a wonderful course, and every one of us, we have to thrown into the professional field. And in that time, we have to know what are the arguments and how to understand the arguments in a better way. And my dear students, you are in first year, and I suggest all of you, like during whenever we were doing M.Pharm, not in B.Pharm, whenever we were doing an M.Pharm, our teacher used to say us that if you don't learn computer, you will be called as a illiterate man. But now I will say that if you don't know artificial intelligence or the computer languages, I am not talking about the computer, I am talking about the computer languages, then will be, after few days or after few years, will be called as outdated man. So my personal suggestion is that please, train yourself, that is Python, that is the basic to learn artificial intelligence. So Python for everybody. Then chemistry is there, human physiology is there. So this list of courses are available for the Coursera, which is essentially to be known for any students of pharmacy. So that is what in first year students, those who are, those who are going to second year, or those who have joined, that at present in my institution also the admission process is going on. Those who are taking admission, I suggest them that you please go through these courses and please update yourself. Okay. And for second year, after understanding the Python, at least second year students, that they can understand the what is cyber security and its 10 domains. You see, at present, if we don't understand the securities, especially cyber security, then obviously, it will be very painful for our professional future. So they, again, anatomy, then physical chemistry. So these are the list of courses which is available. I'll request if the slides will be useful for all of you. I'll share the slide to Dr. Vishnu Vishwal, and he can share to all the participants and if they require. Okay.
Okay, thank you, sir. Thank you, sir.
Yeah. I should go in this way only. Yeah. For like Coursera for the third year and fourth year student, and for M.Pharm students, like I have mentioned a few courses like design thinking and innovation, because whenever we are coming into third year, we must start thinking something innovative. Like Dr. Vishwal, while introducing myself, actually, probably he has missed one. That is, actually, I have filed 11 patents. And one patent has been published. And for all of your information, during COVID-19, I have filed 5 patents. So we have to think something differently. And I suggest, third year, fourth year student, take help of your teachers. And first of all, if you think it is an innovation, and first, you have to learn how to protect your innovation. Okay, that is called as intellectual property rights. And my email ID is there towards the end. Any participant that need anything in the future, they can contact me. Certainly, I'll contribute. I'll be happy to contribute the students. Okay. Then you must have to learn what is the drug discovery. And I suggest here the drug discovery that the Smart India Hackathon, they are keeping a series of sessions on the drug discovery. You people can join there, and if at all it is possible. Then drug development, drug commercialization. So these are the courses for third year, fourth year, and M.Pharm. And M.Pharm students, they must have to think differently. You see, this COVID-19, like all the professionals, I usually, after 5, I don't, I planned in such a way that I never worked it in my home, but at present I'm working till 8 to 9 p.m. because I got a tremendous scope to learn something else what I have learned before. So please plan accordingly. Okay. And these are the free online courses. When we are sitting it here, but we can do a few courses of MIT. And before, I'll suggest all of you, don't do any courses, don't attend any webinar or any conference for the sake of the certificate, because that will be very much painful for you in future. So for example, you have done a course on this MIT platform, for example, in principle of pharmacology. As an interviewer, I understand that you know much more on pharmacology than any other students or any other candidates. So if you don't have better than that, then it will be a punishment for you. So don't do such courses. So these are the courses I suggest all the pharmacy people, because they're like Amalendra Basu sir is there. He's a giant in pharmacology, and he can suggest you in better way. But these courses are very wonderfully designed, and the principles and practice of drug development. This you can go through, and this is again international platforms are there, like here, principles of drug development, and then pharmaceutical management for unresolved populations. Then is your, in SWAYAM portal also, you can there are many courses in SWAYAM portal. So these are the online certification courses in biotechnology. You see, don't confine yourself that, being a pharmacy, I should know only about tablet and capsule. Please make yourself open to learn many things. If you want to go deep into the any area, first of all, you should have a broader knowledge, and then you can make deeper into a particular knowledge. But if you don't, if you have not learned how to narrow down, then it is a problem. But first of all, to narrow down, first of all, I should have a overall knowledge. So there are e-Pathshala also, that is on pharmaceutical sciences. The India top teachers are teaching here. So please update. Don't be confined to your course. At present, in pandemic, especially it has taught us, don't we should not be confined to only one area. So these are the Nalanda e-Consortium. You go to my laptop, the students, because mostly this semester we may have to go online mode, so you can get wonderful journals and wonderful books in this my laptop. So please use this, and directly I have included the apps here, and you can just take help of this link. These are the paid online training courses, that is international, that is Harvard Medical School. Okay, then Udemy, then is your Coursera. Coursera also, many are free, many are paid. So as for your requirement, you can go ahead and you can select the courses. Okay, and these are all about how to strengthen ourselves in principally that my knowledge. I don't say that after pandemic one will carry the full bag with the certificates. Okay, and the next part, this is what I have mentioned, how to make use of your time. But here, I want to say few points how you can make yourself healthy and happy, because all of you are young, and please take care of yourself and your family members. So please, just a few tips I'll be giving you. I'll be concluding within next 10 minutes. So what is the efficient way of management of life? That is, lifestyle refers to the way a person or group lives. This include patterns of social relation. How do I react with my society? Now the students, they are forgetting the social relations. The relationship means they understand that is the only relation that mobile. And with an unknown friend, unknown friend cannot, or a partial friend or a jealousy friend cannot be a good or which who cannot give me the happiness. So make a good social relation. Call to your grandfather, call to your grandmothers, call to your elders, call to your youngers, and you'll make yourself very happy. Please have a food consumption very carefully. Otherwise, you will gain a lot of weight, and your behavior should be very normal. During pandemic, whenever we are in lockdown, I found that many people, their behavior became very erratic. Okay, and keep your interest protected, and so it reflects the individual's attitude. Just I'll give you quick tips. Lifestyle diseases like diabetes, obesity, and cancer, AIDS, these are the common diseases. Today, ma'am, Papia madam spoke about diabetes. Today we are, all over the world, they are saying that India is the diabetic capital of the world, because we have adopted the lifestyle of developed countries, which is not suiting to our geographic location. So what are the lifestyle related diseases like cardiovascular diseases, Alzheimer's diseases, and the most important is that drug induced diseases or social drugs. What I mean to say that drug induced diseases means either I'm regularly taking certain drugs, and all of us, we should take care of the rational use of the antibiotics and other drugs. And social drugs means here, say for example, I am black, I want to remain, I want to be fair, I started using drugs, and my height is tall and I want to be my height is small and I want to belong. So in that case, I have started use this social drugs without understanding the toxicity of the drug. So this it is very important that we must have to use it very critically. So I'll tell you this blue zone, like a few countries like Japan, probably we people do not know that in these zones like Italy and Japan, dying less than 100 is uncommon. But in India, living up to 100 is uncommon. And here we have to understand why, these are the circles of various countries where the dying is less than 100 is uncommon. Just few points I want to say that. The first one is that if I'm related to my family very well, then I'll live longer. And smoking, one of the, I am asking, what is the advantage of smoking? I have not asked you what are the disadvantages of smoking. I have asked you what are the advantages of the smoking. The smokers, they will be very happy to listen this word, advantages of smoking. I have only one advantage, and what is the most advantage is that they will never be old. What I mean to say that, so before 50 or 60, they have already booked their ticket. So the first and basic principle we should have that no smoking, and we should have plant-based diet. Animal diet is not suitable for especially India like country. Then constant or moderate physical activity, social engagement, and this is the time that we can make a lot of physical activity. And this is the country where we live. We have a lot of respect for the women, what we have learned from the ancient ages also. Take sun bath, and if possible, do yourself in gardening. Okay. So there are various controllable and uncontrollable risk factors. The uncontrollable risk factors, they are like age, gender, ethnicity, and heredity is not in our control. But what are the controllable risk factors? One is habit, behavior, diet is in my control, body weight is in my control, physical activity I have to do, exposure of sunlight, and smoking and alcohol abuse, it has to be there. And the first and foremost thing that at present, when it is not possible to go out, at least whenever you have gone to any place, what you liked most, please close your eye and just think of, it will take you to that place and have a nature bath. I said nature bath. You have to take a good bath there, the place where you have liked most. Okay. There are foods which causes acidic and which is alkaline, and all the alkaline foods should be taken for better health. take plenty of water, okay? And, like at present, all of us, we are saying that immunity is the biggest factor which can protect us from the corona, so COVID-19. So first one is take this green tea, and then eat more beans, exercise regularly, minimize animal fats, increase olive oil and plant sterols, take little bit of garlic, triphala, spinach, oats, and the most preferred one is the lemon water. And first, next one, what I am going to talk, youngsters, please remember that, the anger, we have to compulsorily stop this. We have to put an alarm here. Whenever any anger it is coming, first of all, I have to stop, because the anger, like many speakers, they say that anger means I am putting fire in my pocket. It is not like I am putting in my pocket which will damage the less person. I am putting fire in my brain. How it will put fire in my brain? Because it will create acidic environment, and this acidic environment will spoil all of my vital organ. So whatever the reasons may be, say for example, the opponent is totally wrong, but I am correct. But even if I am correct, why should I spoil my vital organs? Can the opponent give me his vital organ to me? Why should I lose it? So stop it. Put a alarm here. Keep your biological, alarm here. That whenever the anger comes, take little bit of water. That will certainly settle you. Learn to have loving and forgiving. The art of forgiving. Okay, take a bachale. Just leave him. So learn to relax and enjoy life. The life will never end. And have to enjoy the life. Say the boss is having the right to scold us, but why should be worried about that? I have to learn. That is what the important part is, that I have to learn and relax life. So the time is very short because I have to close this one. And please, all of you, make a spiritual habit. Make a spiritual breakfast. Make a spiritual lunch. Make a spiritual dinner. And be thankful to the God before starting the day, because these are the immunity boosters. Okay, so do the prayer, attend spiritual unions online also. Be online.
Yes, Dr. Biplab, what happened? Dr. Biplab?
Yeah. So this one, just to the references. And one, I am very much thankful to Bharat Technology for giving me this wonderful platform to share my views and opinions. Presence of you all, and my special thanks goes to the and Abna sir and all the teachers who are present here, and thank you all. Okay, this is my email ID. Okay, any questions or inquiries, I'll be happy to take. Any queries are there?
Okay, thank you, sir. Hello. Hello, sir, is it audible? How, sir?
It is audible, sir. Continue, sir.
Okay, thank you,
Biswas,
sir,
sir,
for
continue.
for your such great informative session, sir. Thank you once again. So really, in this pandemic situation also, I think it will be very helpful to all the participants. So there are few questions, sir. Hello, sir is there?
Yeah, please. Yeah, please,
Huh.
please.
Hello.
Yes, sir,
Sir,
please.
one question
Yeah.
from Dr. Amalendu Basu, sir.
Yeah.
So one should multitasker, and in that case, will the time management will be difficult to maintain?
No, sir. I know this is a very big question from my teacher. It's not like that. We should be multitasking, but my point was that at one point we should focus in one work only. Everyone, we should be multitasking. And if we plan it that I'll do this work and I'll do that work in the beginning of my, first hour of my office, I think that will be the professional way of doing the work. That is what I understood. And if anything, sir wants to speak also, I'll learn from him.
Okay, sir. Thank you. Hello, thank you, sir. Another question from my guru also, Professor Dr. B.B. Barik, sir.
Oh,
So question
Barik
is-
sir, namaste.
So question is, how holistic approach of health and education excel in life and protect us from different advertises?
Sorry.
How holistic approach of health and education excel in life and protect us from different advertises?
Yeah, actually, without the health, we cannot work efficiently. That is, if we have lost our health, we have lost maximum. So in a painful condition, we cannot learn much and we cannot deliver much. Say, for example, if I am at pain today or now, I would have delivered very miserably. As because I am healthy today and my health is cooperating with me, that is what I could give maximum during this last 30 minutes. So that is what we have to plan in this way. The health and education and professionalism, everything, it depends on our health.
Okay, thank you, sir. Once again, lastly,
Pranam to my
I will-
gurus. Pranam to
So-
my gurus.
okay, once again,
Yeah.
lastly, I would like to thank you, sir, for giving us your valuable time instead of busy schedule.
Thank you, sir.
Okay, so Next we'll go to- yes, sir.
I shall take leave, sir, because I have a meeting at 12. I shall take leave. Okay. Thank you, sir.
Okay,
Thank you
okay,
all.
sir. Okay,
Have
sir.
a great.
Okay, thank you, sir. So now we'll move towards our third session. Now it's my honor and privilege to introduce our third speaker of the session, Dr. Swastika Ganguly Madam. So, Madam has completed B.Pharm and M.Pharm and PhD from BIT Mesra Ranchi, Jharkhand. After completion of PhD, she joined in Department of Pharmaceutical Sciences, BIT Mesra, as assistant professor in the year 2001. She promoted to professor in the year 2015. Madam is actively involved in research in the area of computer-aided drug design, along with drug synthesis against HIV and allied opportunistic infections. Madam had more than 21 years of teaching and research experiences. She has guided more than 30 M.Pharm students and 11 PhD students. Madam has successfully completed 4 research projects, including 2 major projects from UGC and AICT. Madam has published more than 120 research papers in various peer-reviewed journals of international and national repute, and also presented more than 60 papers or posters in various international and national conferences. Thank you, Madam. So now I would like to invite Dr. Swastika Ganguly Madam. Please carry on, Madam.
Yeah, thank you, Mr. Vishnu Biswal.
Thank
Am
you,
I
madam.
audible to you?
Yes, Madam, audible clearly.
Yeah. So I think there was a change in your plan and program. Previously, your convener had send
Sir,
me
for-
the
For
flyer.
that, we are sorry, sir. Sorry,
Yeah,
madam. For
because
that, we
I
are
had to
really sorry.
leave a meeting at 12 o'clock. I had a
Okay, okay.
important meeting, a webinar, but I had to leave it and I was waiting for this lecture to complete. So anyway, I have tried to adjust however
Okay,
much
okay.
it is possible. So
Thank you,
shall
madam.
I
Thank you.
start my lecture? Shall I share my
Yes,
screen?
yes, madam. Yes, madam. You can share your slides. No problem.
Yes, can you please see it?
Yes, yes, madam. Just to
I
make
will
it
just
full,
make it
madam.
slideshow. Please
Make
wait.
it
I'm
full
making.
screen. Madam, make
yeah.
it full screen. Okay.
Yeah, is it visible
Okay.
now?
Yes, yes. Clearly visible, madam. Carry on. No
Okay.
problem.
Okay, so please others, please mute yourself. Otherwise, there may be certain types of music which we may not like. So today my topic is 3D QSAR and overview. Now 3D QSAR. Before embarking on 3D QSAR, we would like to know what is QSAR. Quantitative structure activity relationship. This can also pertain to qualitative structure activity relationship. For example, I would like to take you to the local anesthetics. In local anesthetics, in case of those who have studied medicinal chemistry, if we study the structure activity relationship, we will see that we have a hydrophobic portion and a hydrophilic portion, and we need both those hydrophobic and hydrophilic portions to be optimum so that the local anesthetic can enter the aqueous layer and then act on the hydrophobic portion of the receptor where it is supposed to act. So there has to be an optimum level of the structure, let's say hydrophobicity and hydrophilicity, for activity to be important for local anesthetics. But what we have studied till now, we are all qualitative structure activity relationships. But if we go on with our qualitative structure activity relationships, there are certain hindrances. So we go to quantitative structure activity relationship. What is quantitative structure activity relationship? Now, I will show you an equation. Okay. Now, this is the equation which says biological activity is a function of the physicochemical parameters of a drug molecule, which means that biological activity will depend on what the physicochemical parameters of a drug molecule will be. And this can be quantified because this is a mathematical relationship and we are able to form an equation. Okay. So let's come to the things which you can do with quantitative structure activity relationships. First is you can develop quantitative structure activity relationships. You can predict the properties and activities of untested molecules, which is the most important of all the things that we can do with QSAR. We can optimize the properties of a lead compound. We can compare different QSAR models statistically and visually and find out which one is the best. When we do it visually, you will see we will have contour maps. And that is the beauty of quantitative structure activity relationships, particularly 3D quantitative structure activity relationships. Now, we can also understand the characteristics of a receptor binding site. The characteristics of a receptor binding site. Why am I telling this? Because all the time you don't have a receptor to relate to. There are a number of receptors which have been X-ray crystallographed and are there in the protein data bank, Brookhaven Protein Data Bank, which is now known as the RCSB, Royal Collaboratory of the Data Bank, of the Protein Data Bank. Okay, so there are a number of receptors which have been co-crystallized, but there are again a number of receptors like GPCRs, G protein coupled receptors, about which we don't know anything. So QSAR can give you an idea about the receptor binding site. It can also validate models of receptor binding sites. Now here when I am doing, I will have to be, somebody is wanting to get admitted, I don't know. I will have to validate, I will always come to this point, this word, that is validation. So you can believe in a software only when you validate that software. Even in case of instruments, you do calibration. Say in case of the very minute instrument, that is the weight box, a digital weighing box. So what do you do in that digital meter? You first tier of how much should be the value of the paper which you are putting, and then you place your compound for further weighing. Now here, that is how you are validating the instrument. Here also we have to validate the QSAR, we have to validate the models of receptor binding sites, we have to validate the receptor itself, and how we will do this, we'll come to the next slides. With QSAR again, you are able to prioritize compounds for synthesis or screening. What are the compounds which you will actually go for synthesis or screening, or else people can make hundreds and thousands of compounds. And what you come when you do the wet lab experiment, the pharmacological screening, you find that only 1 or 2 are showing some activity. So what this quantitative structure activity relationship can do is it can give you an idea about which compounds to synthesize, which compounds to screen, how to design a better drug. So let's see, I have been talking about what are the physicochemical features. There are structural features, there are physical features, there are chemical features. Physical and chemical features are together known as physicochemical properties. I better like to describe them as descriptors, because descriptors describe the molecule. So I like to say that they are descriptors, or else we can always coin it as physicochemical. So let's see, how many physicochemical properties of the drug should you take? How many physicochemical properties will a human mind be able to comprehend? So what we do is we take 1, 2, or at the maximum 3 physicochemical properties, and we hypothesize that the other properties are remaining constant. So what are those 3 physicochemical most important properties? One is your hydrophobic property, which consists of partition coefficient. I think all of you here know about partition coefficient, and the subsequent hydrophobicity constant, which is denoted by pi. Okay. Now we have electronic. See, what we are talking here about is 2D QSAR, two-dimensional QSAR, where we have got graphs and lines, but we do not have any 3 dimensions. So here in electronic properties, we'll come up with the Hammett substitution constant, which is there for the aromatic rings. Steric constant is also there, and for that we have Taft's steric factor and molar refractivity, which will give you the molecular volume of the complete drug which you are, or any candidate or any new chemical entity which you are taking. So at the most we can take these 3 parameters, make an equation which is called the Hans equation. We also have another steric parameter, that is Verloop steric parameter, which is done by a computer program which is known as SteriCMol. Okay, we'll keep the other physicochemical parameters as in a certain constant. That is, we will think that these are in some kind of constant, and we will vary these 3, that is hydrophobic, electronic, and steric factors. And what we get is the Hans equation. Now, Hans equation, we can see that is log 1 by C is equal to K1 log P plus K2 sigma plus K3 ES plus K4. What kind of equation is this? This equation is Y is equal to mx plus C. K1, K2, K3, K4 are the constants. 1 by C. C is the concentration of the biological activity. Now it can be MIC, it can be Ki, inhibition constant, it can be IC50, it can be anything, but we have to take the log of that 1 by the concentration of the amount which is showing biological activity. Why this log is to be taken? Here in the whole equation, you will see log P is there, K2 sigma, K3 ES, K4. We have to remove the skewness of the parameters. If we don't take log, if we take only 1 by C and K1P, then what will happen? Will all the points go haywire and you will not get a linear graph. So to get a linear graph, we are using this kind of logarithmic terms. Now, Hans equation, it is called Hans equation because Hans was the father or the pioneer of QSAR. Next, we have Craig plot, the Topliss scheme, the Free-Wilson energy approach. I will not take any time for describing this because I think when you are studying drug design, all of you must be familiar with the Craig plot, which consists of the pi and the sigma, that is the steric and the electronic factor. The Topliss scheme is a scheme for aromatic substituents as well as aliphatic substituents, and from that scheme we can narrow down how many compounds we have to synthesize. And then we have the Free-Wilson energy approach also, which also is depending on the substituents itself. So because if I take the time to explain this, then my time will be gone. So I will be coming to directly to the 3D QSAR study. Before the 3D QSAR study or any QSAR study, what are the parameters to be studied? There are 3 physicochemical parameters are to be studied. You have to plan analogs, compounds that the parameters studied are suitably varied, and you have to have enough structures, enough synthesized structures to make the results statistically meaningful. Actually, what is a QSAR? QSAR is nothing but a statistical study. So let me tell you, from the rule of thumb is you have 3 physicochemical parameters and you have 5 compounds for each physicochemical parameters. So ultimately, how many compounds at the least are required? 15. 5 into 3. 15 compounds are at the least required to plan a QSAR study. It can be 15 or more, but it can never be 15 or less. So now we come here on the 3D QSAR. 3D QSAR is called 3-dimensional QSAR. I have given you the name of the 3-dimensional QSAR here as comparative molecular field analysis. Now, this is also known as COMFA. However, please don't think that we are publicizing COMFA. It is not like that. There are a number of softwares, 3D QSAR softwares, like Accelerate has its molecular field analysis, MFA. Then V Neural Networks has K Neural Networks, MFA. So there are number of 3D QSAR softwares which different companies are selling with different names. We will just see the basics of the 3D QSAR and how you will prepare a molecule for subjecting it to 3D QSAR. But we have found that COMFA had been the most popular and widely accepted 3D QSAR approach. So we have also in our institution bought COMFA from Tripos and we are using it. Along with that, we have COMSIA also, which I will also be telling you. Now, just to see the birth of 3D QSAR from Tripos, in 1979, Kramer and Milne, they aligned the molecules in space and mapped their molecular fields to a 3D grid. Then they gave the name DILOMS. DILOMS means Dynamic Lattice-Oriented Molecular Modeling System. Now in 1986, instead of principal component analysis, there was a new regression method which was called partial least square method to correlate the field values. Field values means the COMFA values with the biological activities. And in 1988, a key publication in JACS came. That was the first COMFA publication by Kramer. So this was as far as the history grows for COMFA, or you can say 3D QSAR of Tripos. Now, let's see what are the aspects we'll consider for a COMFA analysis. First is your biological data. Second, see, all the points are given here, and we will be discussing each and every point in the next slides. Biological data, selection of compounds and series design, generation of 3D structure of ligand molecule, conformational analysis of each molecule, establishment of the bioactive conformation of each molecule, binding mode and superimposition of the molecules, position of the lattice point, choice of force fields and calculation of interaction energies, statistical analysis of the data and the selection of the 3D QSAR model, display of the result in contour plots and interpretation of them, and design and forecasting the activity of unknown compounds. Well, I read out this slide because after this, we are going to deal with each and every point of this slide. So the first point was biological data. Now, see, QSAR is a statistical study. For this, you will need to have a set of ligands. Now, ligands, of course, means compounds. Now, when you are planning to do a QSAR study, you will consult many journals. And suppose you are targeting towards, say, COVID-19, though we have not come up with so many compounds for COVID-19. Let me take the example of HIV, reverse transcriptase. So there has been lots of literature on HIV reverse transcriptase inhibitors. So if we take a journal, say, we want to get a set of non-nucleoside reverse transcriptase inhibitors. So what we have to do is we have to take that journal and we have to see whether those authors have done further work in the same laboratory using uniform protocols and ideally from a single source. It means that it should ideally be from a single journal, or it can be from some different manuscripts, but they should have been worked out by the same authors in the same lab. Otherwise, there may be discrepancy because the environment may not be same, the lab conditions may not be same. So this is one thing, is you have to obtain a set of ligands which should have uniform protocols. Now, the biological activity, how will you take the biological activity? One is when you are doing a set of molecules, say seeing the activity of a set of molecules, what you are doing is you will find in most of the molecules, they are giving, say 15% give high activity, or say 25% give high activity, 25% or 50% give medium activity, and the rest 25% don't give any activity, or the activity is not determined because of some certain parameters, some chemical parameters. So the biological activity ranges should be covered from high to no activity. That is what we have written here, that biological activity ranges covered should be as large as possible. Now, their mode of action must be identical. Now, when we are doing 2D QSAR, we could take any number, like we could take only the homologous series of the molecules. Say we have got CH3, C2H6, C3H7. So what is this? This is a homologous series. But in 3D QSAR, you need not take a homologous series. You can take a 5-membered compound, and you can take a 7-membered compound, and you can take their analogs, provided their molecular mechanism of action is exactly the same. So if we give the example of HIV reverse transcriptase inhibitors, some students of mine have done with indoles, like here Dr. Biplab has done work with indoles. We have worked with thiazolidine diones. We have worked with pyrazoles and pyrazolines. We have worked with imidazoles and imidazolines. So many molecules we can take together for doing a QSAR because their mechanism, the molecular mechanism of action is identical. That is, they are acting particularly in the non-nucleoside inhibitory binding pocket of reverse transcriptase, particularly on those residues which the active site is comprised of. So we already know, we have seen in our 2D QSAR also, biological potency will be defined as log 1 by C, where C is the molar concentration of the drug producing a standard response. Now, you don't know anything about the receptor. Well, if the receptor is there, well and good. But if you don't have the receptor, then drug design has to be done by some kind of 3D QSAR or 2D QSAR. So what we hypothesize here, we imagine here that the possible conformational changes of the receptor are equivalent among all the compounds. That is, we take the receptor to be a rigid structure, and the conformational changes are also considered to be equivalent for all the compounds, particularly where we do not have a receptor. Okay. So we come to selection of compounds and series design. That is the second point. Let's see, there are three major issues in choosing substituents from your journal, say from the manuscript. First is there is minimization of collinearity, maximization of variance, mapping of substituent space with smallest number of compounds. Now, what are these terms which I am telling? Minimization of collinearity means let them not be the same. Let them not be the same homologous series. Let's say we have got chlorine for halogens, we have got fluorine, we have got iodine, we have got bromine, all are halogens. Similarly, we have methyl, we have got ethyl, we have got propyl, we have got heptyl, we have got pentyl, we have got butyl, sorry, pentyl, then heptyl. We will have to minimize this collinearity. We should be able to take variation of substituents. Why? Maximization of variance. Why? Because what you are going to do with this QSAR is you're going to predict the activity of your unknown compound, which may have completely different substituents. So that is why we say that there's the mapping of substituent space with the smallest number of compounds. So what we are trying to do is getting a number of different substituents, thus mapping the substituent space. We call it a substituent space, and we are doing this with, say, 50 compounds or even with 15 compounds with the smallest number of compounds. Now, whatever I am telling you here is ideologically possible, but many times it is not possible pragmatically. Okay. Now, why should we do this? The ideal answer is we want to get a robust 3D QSAR model. What is a robust 3D QSAR model? It means that the 3D QSAR should be able to predict the activity of unknown molecules, and when we synthesize those molecules and go for wet lab screening, the molecule should show similar activity as was predicted by the 3D QSAR model. So that will narrow down our harassment, narrow down our chemicals, narrow down the animals which we have to test. So that is giving us all these kind of advantages. Now for this here, I have written one term, that is training and test set. Now what is a training set and what is a test set? Training set is the set with which you will do your QSAR. Once I come to the case study, I will show you what a training set is. Test set, you will keep away from the training set, and your model should be able to predict the activity of the test set. And you will compare it with the activity already given. Because what we are doing is we already have taken some molecules from some publication, we have the activity, we have the molecules, and we take a database of molecules, we convert them into training and test set. Now you will tell, how will we know which one is training, which one to be included in training set, which one to be included in test set? In training set, I told you, as much as possible, try to be diverse in your choosing, in your specification. And one more thing is, the rule of thumb is 1:4 ratio. That is, if test set is 1, then training set will be 4 compounds. So if we have say a basket of compounds, like 50 compounds, then 40 compounds will be there in training set and 10 compounds will be there in test set. And so the ratio will be 1:4. And again, this is also being done to make a robust 3D QSAR model. Okay. Now we will see generation of the structure of the ligand molecule. Okay. How will you generate the starting structure? Now there are different methods. And then how will you optimize the starting structure? So the methods for generation of structure, one is you can get the X-ray crystallographed protein if it is present in your rcsb.org, download it. You will have a co-crystallized ligand with the protein, extract that ligand and start building your structures from that ligand. Because the ligand which was bound to the protein structure is actually in its highest active conformation. So if you can extract and draw your ligand from that, then possibly you're also getting the bioactive conformation. Now, suppose if this receptor is not present, then you will go for molecular modeling. And molecular modeling means you will draw structures in your molecular modeling software. That is, it can be ChemDraw, it can be ACD ChemSketch, it can be ISIS Draw. You have different free softwares for drawing the structure and for optimization of the structure. So once you have drawn a structure with Scratch, some imidazole, there's no, you don't know bond length, bond angle, nothing like that. So I was giving yesterday the lecture on that only, that how you will optimize that structure which you have drawn. So every molecular software has got some kind of geometry optimization menu. Either it comes in the form of clean the structure, or it comes in the form of optimization of the structure, or it comes in the form of geometry optimization. So there are various methods for optimization of the structure. One is molecular mechanics, and the other one is quantum mechanics, which again has two methods, that is semi-empirical and ab initio. Now, molecular mechanics is used for bigger macromolecules. Now, what are the macromolecules? The proteins. We have to refine our protein also when we are going to do molecular modeling. So molecular mechanics is taking less computer time when it is subjected to macromolecules, whereas if we subject semi-empirical or ab initio, then your computer will just hang. So semi-empirical and ab initio are generally taken for lesser atoms. Ab initio requires more computer time, so it is done for tens of atoms. Semi-empirical, lesser computer time than ab initio, but more computer time than molecular mechanics. It can consider tens and hundreds of molecules, and molecular mechanics can be opted for very large macromolecules. So let's remember here that when we are taking a structure, we are actually preparing a molecule for a 3D QSAR study. So when we are taking a structure here, we have to first draw the structure, or we have to get the structure from X-ray crystallography, provided the receptor is there, and then we have to optimize the structure. That is most important, to get the correct bond lengths, bond angles, torsion angles, dihedral angles, and all other things. Now, after this, we come to the next point, that is the conformational analysis of the molecule. Conformational analysis of the molecule can be done by 4 methods. One is the systematic search method, that is grid search. One is the molecular dynamics method. One is the Monte Carlo method, and the distance geometry approach. So we'll see all these methods in our next slides. First is the systematic search method. This, of course, will be done by conformational analysis, and a thorough conformational analysis will be done. Now, what is a conformational analysis? What is a conformation, firstly? Conformation is the arrangement of molecules in space, of the atoms in space, particularly. So let's see, we all have 3D structures. We have got 3D molecules. We have got 3D receptors. So we have to see the energy minimization. So first, when we did the molecular mechanics and semi-empirical and ab initio, that was the local energy minimization. Now, when we are going for systematic search and other methods, we are going for the global energy conformation. Now, how will you distinguish between a local energy conformation and a global energy conformation? See, suppose I throw a ball. I threw a ball, it hit the floor, and the point at which it hit the floor is the local energy minimum. That is where it is coming to rest at the first point. After this, this ball is bumping and bumping, and after that it comes to rest slowly at a certain point of the surface of the floor. So that point is known as the global energy minima. So what our systematic search method does is it finds out the global energy minima. Now we will see all the methods and just a comparison between the methods, that which one is good for what. In systematic search, what we do is we give the dihedral angle a value of some increment. Say we give 30-degree increment. There are 3 rotatable bonds, and the bonds will be rotated around 360 degree. So 360, the formula is 360 by the bond angle, that is 30 degree, to the power 3. 3 is the number of rotatable bonds. So 360 by 30 to the power 3, we will get 216 or somewhere around that number of conformers. So here, this is a time-consuming process, and time increases exponentially with additional rotational bond. However, this cannot deal with the ring closure problem of cyclic structures. That is, we cannot have rotatable bonds in our cyclic structures. So we'll go to the next method. Sorry. Molecular dynamics method. molecule we know is a dynamic structure. Now, there is kinetic energy, there is potential energy. Changes with respect to time is influenced by its kinetic energy and by interaction energies. What we do here is we do a simulated annealing. Simulation means mimicking. Annealing means subsequent cooling. So what we do is virtually we heat the molecule to a certain temperature, 1000 Kelvin, say. So the temperature of the system, it is risen to 1000 Kelvin, and then it is subsequently cooled. And what happens when it is heated, say virtually only, the rotatable bonds become free and several different low energy conformers are obtained. Once it is free, you know, it will be going on rotating and rotating until and unless it gives you the different low energy conformers. So we have seen from our experience that we can get 500 conformers if we do this simulated annealing method in the Sybil graphical user interface. And after getting those low energy conformers, we can manually select that which one has got the least potential energy and the least kinetic energy. And from that, we can take up that molecule only and we can start our rest of the processes. Now that I showed you, that was one method, was systematic search. Another was molecular dynamics. Third one is Monte Carlo method. Now here the dynamic behavior of a molecule is mimicked by the random changes in its structure, and the energy of the changed configuration is calculated. Now if the energy is lower, that means this configuration is stable and can be accepted. But if the energy is higher, then you will have to develop a new algorithm and think whether you can accept that new configuration, or you can again go for another Monte Carlo search and then try to get a configuration which has got a lower energy. Why are we always telling lower energy, lower energy? That is because the molecule is always stable at its lower energy. So here we find that improved Monte Carlo methods are more efficient than molecular dynamics methods. Okay. Next we come to the distance geometry method. Okay, here we can see that distances in molecular modeling software, we are calculating the distances of the molecules, and often students don't know that why we are calculating bond distances. Kya hoga? Why should we calculate these? This is done so that this distance geometry method can be carried out. A random set of coordinates are generated by selecting random distances within each pair of the upper and lower bounds of the molecule. Okay. Then what happens? We have got certain distance constraints in which we have bound our molecule, and this molecule will try to find its conformations within that distance, and it will do it rapidly and efficiently once the distance are given. But because the distances are given, it will not guarantee the generation of all possible conformers, which was happening in case of molecular dynamics methods. It will not confirm the because you know there are those upper bounds and lower bounds have already been specified, so it will move only in that constraint. So this kind of distance geometry method is not practical for larger structures. We can do it for smaller structures. So here again, we have seen that by our practical methods, that distance geometry plus molecular mechanics methods give superior results to molecular mechanics methods alone. Now, this is very important. However, the preferred conformation of an isolated molecule does not necessarily correspond to the bioactive conformation. What happens when we take paracetamol? Paracetamol goes to the particular receptor, binds there, and it does its work of reducing the temperature of the body. Now, do we actually have that insight that we can see the paracetamol going and binding to the receptor? No, we can never do that. So what is a bioactive conformation? A bioactive conformation is the conformation in which the molecule has gone and produced activity by binding in the active site of the receptor, which we cannot comprehend and shall never be able to. But we still have to hypothesize our bioactive conformation. So for this, what we will do? Establishment of the bioactive conformation of each molecule. I told you, bioactive conformation when it is bound to its target receptor. How will it be determined? So we have to take some hypothesis at this stage. One, we can do it by experiment. That is, again, by that X-ray crystallographic method, that already the protein is deposited in the RCSB bank, and from there we are extracting it, and from that extract we are taking our ligand, extracting, taking our ligand, and thinking that because this has given the activity, so it will be the bioactive conformation. Okay. NMR spectroscopy, we all know that we can do the NMR of the protein and the ligand in complex. We can do that also. And other methods are active analog approach. What is this? First, you will do a conformational analysis with the help of systematic search, and you will determine all the allowed conformers of all the molecules. Then you will select those conformers which will satisfy the interatomic distances in the working pharmacophore. Now there are a number of terms here. What is a pharmacophore? A pharmacophore is an essential arrangement of the atoms of the molecule which are required for biological activity. So once you have got the conformers by systematic search, second, you will select those conformers which will satisfy the distances within the working pharmacophore. Say the pharmacophore has got a hydrophobic site, 2 hydrophilic sites. So what you will do is you will try to find out the distances and the bond angles, and you will try to see which conformers are aligning to this pharmacophore. Next, we have ensemble distance geometry approach, which is exactly like the distance geometry conformational analysis. We will generate a set of conformers within the distant constraints. And next is the molecular fitting technique or template forcing technique. So in molecular fitting technique, which I will again come to it because it is a very crucial thing, we will be seeing what it is, or template forcing technique. I'll be just coming to that. Before that, I will just like to tell that these softwares like Disco, Catalyst, Apex 3D software can be used to find bioactive conformation. Now I'll come to the superimposition of the molecules, which is the most crucial step. Superimposition of the molecules, most crucial step. So here we have, say, one of the molecules which we have already there with the receptor, co-crystallized with the receptor. We can take it out. It will be in a conformationally restricted structure, and we can superimpose our molecules on that structure. Say you have got your own molecules, or you have got molecules from a manuscript, then you will take the highest active molecule which you have, and you will try to superimpose all your molecules on that highest active molecule. However, if the molecule is flexible, then it is difficult and time consuming. So there are different approaches for this alignment. One is alignment based on atom overlapping, which I just told you. Take the highest active molecule, take your molecule, and try to click on the atoms, and then the computer asks whether it will align it onto those atoms which you have selected. So you will try to align them on those atoms in the highest active molecule. This is one way. Now, alignment based on receptor binding site. Here, what you will do, if you know the receptor, then you know the binding site, the active site, and you will do your alignment based on that site. You will align all your molecules, try to fit your molecules on that receptor binding site if you know it. And next is you can do it on based on fields or pseudo fields. Now fields, what are fields? What are force fields? Let me tell you, just now you are being subjected to certain force field. What is that force field? It is the gravitational force field, because of which we are sitting and able to see the lecture or give the lecture. If there would not have been any gravitational force field, we would be lying down on the floor. So similar to gravitational force field, the atoms, the structures are also based to three-dimensional fields or pseudo fields like electrostatic and steric fields. So based on those fields also, alignment can be done. However, in our institute, we only have the database alignment method, which is the atom overlapping method. So results, I have put this in red, results of COMFA analysis depends on the alignment of the molecules. Until and unless you can align the molecules properly, you will not get a good COMFA analysis. So let's see the aligned molecules. Some molecules have been aligned. We will see this is in a grid. So many of you maybe who are into drug design already, you know what a grid is. Here we can take the grid to be a pseudo receptor. Now the grid has got, say, what is this? These are the lattice points, the intersection points. These are the lattice points. So what will be done is we will place a probe in this grid. It may be a proton probe, it may be a methyl probe, or it may be even a hydroxyl probe. And we will calculate the interaction of this lattice point to this point of the molecule. Similarly, this lattice point to this point of the molecule, this to this, and this will go on. And this will take place with all the lattice points. So is it possible for a human mind to comprehend so many interaction energies? Whatever it is measuring is called the interaction energy. Say we have got our steric and electrostatic fields here. Okay. Please, somebody, please mute yourself kindly. So we have to see the position of lattice points, how much will be the position. The size of grid spacing has to be 2 angstrom. Size of grid box has to be 3 to 4 angstrom. And the location of the grid box has to be seen, whether it will be on the receptor. If the receptor is not there, it will be on the center of the GUI. And then you will construct the data table. Now, what that data table will contain? Data table will contain one column will be of biological activity, which you have got from your published paper. One table will be the interaction energy fields, which just now I showed, that is the measuring from the lattice point to the molecule to the point of the atom. So there will be 2 columns. One will be biological activity, one will be interaction energy fields. And interaction energy fields, calculation of interaction energies, I have already told you. But now what we have to see, that this calculation of interaction energies, I've told you, by a probe or water or a methyl group. Can we comprehend these interaction energies? For one part of the molecule, there will be thousands and thousands of interaction energies depending on the lattice of the grid. So then what we do? But before what we do, we will just see the molecular force fields, which I have been talking about. Force field, as just now I have given you the example, empirical fit to a potential energy surface. That is the definition. Now, the force field uses the combination of bond distances, bond angles, torsion angles, interatomic distances to describe the bonds, van der Waals interactions, and electrostatic interactions. So all this comprises of the force field, and the force field parameters are again derived from the empirical data of a small set of molecules. So first we know that what is a force field. Now we come to what are the different forces which are taking place on the drug when it is interacting with the receptor. One is your electrostatic. See, in 2D QSAR, we had electronic. Here we have electrostatic, which is a 3D physicochemical parameter. Hydrogen bonding. Both these will give you the specificity of the molecule where it binds to the receptor. Next, we have van der Waals forces. You all know what van der Waals forces is. Hydrophobicity, very important, because our cells are optimally made of hydrophilic and hydrophobic layers. So this van der Waals forces and hydrophobic forces are required for binding, whereas electrostatic and hydrogen bonding are for specificity. Now, when we are doing COMFA, that is comparative molecular field analysis, steric and electrostatic force fields are important. Here we are not considering the hydrophobic force fields, which is a disadvantage in this case. Okay, we'll come to that also. So now we are preparing our molecules, and for that we need to pre-treat the data, pre-treatment of data. We have got a number of molecules, we have got biological activity. Now we have to see, this is raw data, we have to pre-treat it to reduce some data. Now I told you some molecules may not have activity at all. You can leave those molecules. So reduction can be done by standard deviation. Reduction, the default cutoff value is 2. That is, if the standard deviation is more than 2, you can filter it off. That is, you can eliminate that molecule. If the reduction is by energy cutoff, then that will be steric energy. The cutoff values is 30 kilocalorie per molecule. That is when it is doing the conformational analysis, etc. If you find that the energy is more than 30 kilocal per molecule, leave it. So that gives you the raw data forming into your correct data. Some of the molecules have been left. Now we will do, if somebody can just remove this window from here, we can see that there is PLS, partial least squares. Is it possible to get this window removed? This, what I can see here. I can't remove it. Anyway, we have here partial least square. That is the statistical analysis of the data. I told you QSAR is statistics and nothing but statistics. Now, when we were doing 2D QSAR, it was MLR, multiple linear regression. But here, I think you can see it or you cannot see it, I don't know. It is partial least square, PLS, partial least square method, which is this can be applied to hundreds or thousands of variables. I told you interaction energies will be thousands and thousands. So these interaction energies can be summed up to one energy. That is, for one lattice point or for one point in the molecule, there will be one energy. So that is the COMFA value. So PLS sums up all these variables and puts it into one latent variable. Now, this PLS can involve only small number of biological data because you know you may not have very much large amount of biological data. It can be used with variables which are highly collinear among one another. That is, they may be having the same kind of variables because same kind of substituents may also be there. Then multiple biological activities can be handled easily. So if you have MIC, minimum inhibitory concentration of one bacteria or two bacteria, or say 2 gram positive, 2 gram negative, it can handle all these biological activities simultaneously. And this is a repetitive procedure. Iterative means repetitive procedure to provide you with a robust 3D QSAR model. So what happens is, as I told you, PLS summarizes hundreds or thousands of descriptor variables into few new variables called as latent variables. These are also known as the COMFA descriptors. In 2D, we had the molecules, we had the physicochemical parameters. Here we have the molecules, we have the biological activity, we have the COMFA values or the COMFA descriptors. Now let's see the PLS statistics. What are the statistical parameters which the computer will calculate for you and which you may have to calculate manually? One is the cross-validated correlation coefficient. Now here in cross-validated correlation coefficient, you will have a leave one out method or leave group out method. Okay, So leave one out method is, suppose you take 50 molecules. Now in those 50 molecules, you eliminate the first molecule and do a PLS of 49 molecules. Now you see, you predict the activity of that first molecule and you find that that activity is not so similar to the activity mentioned in your manuscript. That means this molecule must be having some value or some property which is not being included. So what you do, you include that molecule, you eliminate the second molecule and do the PLS. This way you do the same thing again and again to eliminate all your 50 molecules, and then you can get a leave one out procedure, and that is where you can get your cross-validated correlation coefficient, which will be a robust R-square CV. Then you have standard error of prediction. We have in our statistical analysis methods. N is the optimum number of components. That is, if you have electrostatic and steric, there are 2 number of components. Then you have R square, that is conventional correlation coefficient, where you do not leave out any molecule, and this conventional correlation coefficient should always be more than 0.9. It should ideally be 1, but it will never be 1. It should be more than 0.9. Then you also have the standard error of estimate. And finally, you have R square predicted. That is the predictive correlation coefficient, which is very important. And that has got a formula that is SD minus PRESS by SD. So I have given SD is the sum of the square deviations between the biological activity of the test set and the mean activity of the training set molecules. PRESS is predictive residual sum of squares. This is sum of square deviations between predicted and actual activity values for every molecule in the test set. Now this has to be calculated manually. So this R square predicted should also be more than 0.6. R square CV should also be more than 0.6 for you to believe in the QSAR model. So validation, just like I said, this cross validation, bootstrapping. Bootstrapping doesn't mean strapping of boots. It means that you can take a random number of compounds, leave them out and do the PLS, and again leave another random number of compounds, do the PLS, and what you will get is an R square BS. That is the bootstrapping correlation coefficient. You can also change the dependent variable value. Now, what is the dependent variable value here? The biological value is the dependent variable value. So that can be randomly changed and seen to get a robust model. And then I have already told you dividing original set into training set as well as test set. So that I have also told you the ratio. It should be 1:4. So next we come to the beauty of for the 3D QSAR. You have contour maps. These are generated as a scalar product of coefficients and standard deviation. So you have steric field contours because we are taking here only the steric and the electrostatic in consideration. So here we have the steric field contours, which if green is steric favored, yellow steric disfavored. Now this can be customized by you, but whenever you customize it, you have to mention it in your publication that what color have you given to steric favored, what color have you given to steric disfavored. Similarly, electrostatic field contours are also there. Red is electronegative favored and blue is electropositive favored or electronegative disfavored. So COMSIA. Now we will come to, this is an extension of COMFA, the comparative molecular similarity indices analysis. Now here what we can see is there is steric, electrostatic, hydrophobic, hydrogen bond donor and hydrogen bond acceptor. Now these three fields were not present in our COMFA. So obviously COMSIA becomes better than COMFA, and the contour maps, again, hydrophobic favored can be yellow, disfavored white. I'm not going for the colors because colors, you know, you can customize it yourself, okay, when you handle the software. So I will just go, I think I don't have much more time. I will just show you a case study which we have done in our labs and of the MPharm students' works for many years, and then we have got a data set. So we have done the COMSIA analysis of one substituted imidazole analogs as Candida albicans P450 demethylase inhibitors. Let me tell you, Candida albicans P450 demethylase is a GPCR and it has not been crystallized to date. So here we have got all the parameters which are to be taken. We took 66 molecules. Among them, training set was of 56 molecules and test set was 10 molecules. And so we took the MIC data as the biological data. We gave Gestager, Huckel charges, and all these things were done. Alignment was routine aligned database method. So the COMFA descriptors was calculated by the sp3 carbon probe atom with +1 charge. Energy cutoff was 30 kilocalorie per mole. Here in COMSIA, a probe atom with radius 1 angstrom and 1 charge with hydrophobicity of 1 was given. Now in 3D QSAR model, to derive it, we had got independent variables, which are the physicochemical parameters in 2D QSAR. Those are the COMFA and COMSIA descriptors here. Dependent variables are the biological values, that is the PMIC. PMIC means log 1 by MIC. So it is called PMIC. And regression analysis was partial least squares. So we use the leave one out method and we got Q square, R squared, NCV, R squared bootstrapping, standard error of estimate were all calculated for the models. There were different models obtained. So that I will also tell you. And the database alignment method, we took the template molecule core, that is the imidazole molecule, and we aligned all our molecules to this template molecule. After this, we also calculated the R square predicted, which was the formula which I have already told you. And here is the data set which we used. So every MPharm had from, let's say, from the year 1999 to say 2005, we have taken these molecules which every MPharm or both MPharms, we had 2 MPharm students, so give them different structures to synthesize, and we also got the MIC for them. So these are the different data sets and the biological activities. And please see, I have marked A in some molecules. Those are the test set molecules which I did not consider for the COMFA or the COMSIA model. I kept it differently. Now I came to the statistical analysis, and what I find is there are 3 models which are giving us quite good values. But what we find is R square CV is 0.497 in SEA model. What we did is we took the R square predicted value. We find that the R square predicted value for SEA was 0.6. So we took the SEA model to be the best model. Although there were 32 different kinds of model which we found with our COMSIA, we took the SEA model to be the best model. Here we have the one that is electrostatic is 1 ratio to the steric and to the acceptor, one fraction. And this is the fraction that is 3:3:3 almost. Steric is 3, electrostatic is 3, and acceptor is also 3. So now we have got all the models. Other models also, I have just given a brief about them. And in bootstrapping, we also got a high R-square value of 0.993, which could further support for its statistical validity and robustness. So these are the compounds for which we have the experimental value. This is the actual, this is the actual activity. And these are the different activities which were predicted. This is of SEA. So this way we went for all the compounds, 56 compounds, 56 compounds. And this is for the test compounds. So this we got for the test compounds. Now we have here the database alignment, how it looks, because we align on the imidazole structure. Then we have our COMSIA graph where we are predicting MIC and actual MIC. We are taking on the horizontal and the vertical axis and trying to see how much it is going away from the actual PMIC. What we see, it is almost a straight line. They almost only one outlier is there. Then we come to the histogram of test set molecules, both for COMFA and COMSIA. And these are the parameters which you have to show when you have to get a publication for COMFA or COMSIA. Here I told you there are 32 different models, and we found that our SEA model was quite good. So we have plotted the R-square cross-validated against all these models. So coming to the next slide, here we find our best thing, that is the steric contours. So what I had told you, the green contours are steric favored, yellow contours are steric disfavored. So we find a phenyl ring. We can eliminate this phenyl ring if we want a lesser bulky group to be there. And this side of the ring, we can include some higher bulky group. So if you see my inference, I have given here, yellow contours embedded the whole molecule. Introduction of bulkier groups decreases the biological activity. Green contours are not well oriented towards the molecule, which you can see. So substitution of bulkier group, we come to the inference that it decreases the activity. Similarly, for electrostatic contour maps also, we have electronegative favored and electropositive favored. Let's not say electropositive favored, let's say electronegative disfavored. And here again, we have the inference, that is blue contours are embedded in the second position of the imidazole and phenyl group at the first position of imidazole, which means that introduction of electropositive groups I have written, but you can say also that there is no need for electronegative groups to be in the second position of imidazole or in the phenyl group. And here, where there are red contours, we can easily put electronegative groups. Okay. Now here, because we are doing the COMSIA model, we have here acceptor favored, and here we have acceptor disfavored. So magenta, so acceptor favor means OH, NH, all these are acceptor favored. So here again, I have just given its observation and inference that introduction of hydrogen bond donors at the second position of imidazole may lead to activity, and magenta contours are hydrogen bond acceptors. So these can be at the place where magenta contours are there, we can have hydrogen bond acceptors. So hydrogen bond acceptors are oxygen, nitrogen, all these kind of things. Now, this lastly, I come to the 3D QSAR pros and cons. Every software or every model is not without its disadvantages. So first thing, its advantages are we can describe the receptor ligand interactions, we can know about the receptor mapping, we can do the 3D visualization, we can have a good correlation, we can have the predictive power is much more robust, but the disadvantages are the alignment can be very, very difficult. And until and unless you get a good alignment in the grid, you cannot get a 3D QSAR model. And for this, we require realistic training. So with that, I will thank you for listening to me, for bearing with me for such a long time. Okay.
Thank you, madam.
Yeah, I can take the questions now.
Thank you. There are two questions
Yeah.
from Professor Dr. B.B. Barik, sir.
Okay. Okay.
So question number 1 is, besides 3 physicochemical properties,
Okay.
whether any other property and biological properties considered for drug designing?
Okay. Biological properties are a different thing. Now, let me explain here. The physicochemical properties, I told you QSAR is a equation where biological activity is a function of physicochemical properties. So biological properties is the dependent variable and physicochemical properties are the independent variables. Until and unless there is biological activity, what will we do with the physicochemical properties? Is it understood, Mr. Biswal?
Yes, ma'am. Yes, ma'am.
Okay.
Any other question, please?
Another question, last question, from same Professor Dr. B.B. Barik, sir. How
Okay.
the duration of drug design and drug discovery can be reduced in crisis like COVID pandemic? And are artificial intelligence helpful in such situation?
Yes, of course, artificial intelligence should be useful, but like the deviation between drug discovery and drug design, just now, I do not know whether all of you know there's the drug discovery hackathon going on. There also, they are trying to design the drugs. But the problem is just by designing a drug and next you need to synthesize that drug. And after that, it has to go through all the wet lab experiments, because without wet lab experiments, virtual screening is nothing. So anyway, that time has to be taken. It cannot be reduced if we really want to bring some new drug molecule into the market. In crisis such as COVID-19, I think we are having to repurpose drugs. If we have to come out with some new chemical entity, it will again take 5 to 8 years in the minimum to get COVID-19 out of the system.
Okay,
The
thank you, madam.
vaccines which they are preparing are nothing but the SARS vaccines, which they have modified and they are preparing. We are still not sure about the vaccines. So that is what I can tell you.
Okay, thank you, madam. Now,
Yeah.
I would request our patron, sir, Professor Dr. Ravindra Devnath, sir. Please say a few words, sir.
Good afternoon.
Good afternoon, sir.
We have attended a very beautiful seminar. So this knowledge
Thank
should
you,
be
sir.
thoroughly updated ourselves as well as our faculty members. Drug design and molecular drug design is a very favorite subject for me. I also studied from IICB,
Okay.
Kolkata. Now our younger generation will move in this direction. Very clearly you have explained physics-based, chemistry-based, mathematics-based, everything is clear.
Sir, you have got your student there, Dr. Biplab Devnath, who is a master of drug design. So you can exploit him, or you can explore his possibilities.
That is why you encourage him.
Yeah, you set up a drug design lab. I'm always there with you.
Definitely,
Yeah.
we will go for this one. And at present, the nearby IICB is there. They can-
Yeah.
And our first lecture is given very beautiful way. That is the diabetes. What is diabetes? Concept. Even staff student is not is here. I am also suffering from the diabetes. Sometimes doctor advised 2 tablets, one morning, one evening. And
Okay.
now another doctor says no. 2 tablets.
Diabetes is also a pandemic, sir.
And
Diabetes is also a pandemic.
the concept still now they are not here. Scientists are not here. Now, as a 2 tablet or whole tablet to be taken in the before after breakfast. Sorry, before lunch.
Yes.
So that as soon as the carbohydrate will enter into the body and it will be uploaded in the adipose tissue by glycogen conversion.
Yeah.
Another doctor says that glycogen to deconversion is very difficult. So you take 4 times a day with a small amount. So
Yes.
as the science and technology advances, the concept also changes. So the drug is a very much effective and very useful to the students and staff members and researchers also. Now the world become in our globe, in our hand. So education can be spread all over the world. Or through these web seminars. And Dr. Shahu, he has mentioned very informative, but he speaks on the one hand, that is, what are we are doing, what we have to do, it will be finalized. And that is why, being a member of the ERC committee PCI, we have proposed, in the last meeting, we have proposed our newly established syllabus to be ratified, to be modified with respect to the present situation, coronavirus and other infectious disease, what will come. So we have to fight for this. So for fighting the diseases for the mankind, we have to get the help of genius, that is the scientists, doctors, and other socially involved personnel, so that together we can work to fight for the calamities. Thank you very much.
Thank you, sir.
You have
Thank you
given
for
your
hosting
valuable
me.
time.
Yeah.
I heard you are busy for another lecture.
Yeah, I had a meeting. I postponed it. I'll do it in the afternoon.
Many
Because
thanks
I had
to the-
given word to you. So, okay,
My-
sir. So I'm signing off. Thank you very much. And
I also thanks Dr. Barik, my colleague, and Professor Amamandu, Dr. Amamandu Basu. He's on my guidance philosopher. So we are the friends together. Thank you once again.
thank you. Yeah.
Thank you, madam, once again.
Thank you.
So thank-
As I told you, you can just give me, you can just include me in those things which I have already told you about. If there is any, I'm not just saying it here. I've already told you, I've already discussed it with you. Okay, Biplav.
Yes,
So,
sure, ma'am.
yeah. Okay. Thank you for giving me your time. And
Vishal sir, continue
Okay,
for
thank
the
you,
both
madam.
of
Thank you,
them.
madam. Okay. Madam.
okay.
Just, madam, just for 2 minutes, madam. Just wait.
Okay.
So, Now we have reached at last part of the session. So before that, it's my duty to give a vote of thanks. Once again, very good afternoon to one and all. Myself, Vishnupada Vishwal, Assistant Professor in Department of Pharmacognosy, really honored and lucky to have the opportunity to give a vote of thanks in this special day. So first of all, my most sincere thanks to the management who are always encouraging for conducting this webinar. A special thanks to our convener today's webinar, Dr. Biplab Debnath sir, who is always a pillar of strength to conduct the webinar. I immensely thank to speakers Dr. Papia Mitra Majumdar madam, Dr. Jagannath Sahu sir, Dr. Swastika Ganguly madam for such a wonderful session. A hearty thanks to our chairman of today's webinar, Professor Dr. Kuntol Hazra sir, for his support towards this webinar. My sincere thanks to all the technical teams who are involved in this webinar. Last but not the least, I thank all the participants for being with us all over the session. And at last, it's an appeal to all the participants on behalf of Bharat Technology. Please, in this pandemic situation, please wear masks, maintain social distances, and stay home, and other rules and regulations which is given by the government. Stay home, stay safe, stay healthy. Thank you, sir. The request to technical team, please close the session. Biplab sir, please
Okay,
inform.
yes. Thank you, everyone.
Okay.
Okay.
Okay, goodbye.
Okay, sir. Thank you. Let me sign off then. It was a
Okay,
wonderful
okay, madam.
platform.
You can sign off.
Thank you so much.
Thank you, madam, once again. Thank you. Gauranga sir. Hello.
Hello.
Gauranga sir.
Yes, sir.
Please close the session. Please close the session. Okay.
Okay, sir. Okay.